feel free to text your question if you have one, but in the interest of time, we are going to have to try to streamline some of those questions. So just make sure that you can reach out to any staff members or put your question in the chat if you are on Zoom today. So we are going to go ahead and call this meeting to order and get started. If you could please take the roll.
Senator Rocky Adams. Senator Berg.
Present in the room.
Thank you. Senator Carroll.
Present in the room.
Thank you. Senator Givens. Senator Harper Angel.
Present remotely in the district.
Thank you. Senator Howell.
Present remotely in the district.
Thank you. Senator Kerr. Senator Meredith. Thank you. Senator Nemes. Senator Wise.
Present in the room.
Thank you. Representative Bentley.
Present in the room.
Representative Bowling.
Here in the room.
Representative Bray.
Here in the room.
Representative Birch. Thank you. Representative Dotson.
Present in the room.
Representative Elliott.
I'm here remotely from my district.
Thank you. Representative Fleming.
Present in the room.
Representative Frazier.
Present in the room.
Representative Marzian.
Present in my district.
Thank you. Representative Gibbons Prunty.
Present from my district.
Thank you. Representative Rayburn.
Present in the room.
Representative Raymond.
I'm here from my district.
Thank you. Representative Riley.
Here from my district.
Thank you. Representative Sharp.
Here in the room.
Representative Sheldon.
Here in the room.
Representative Tate. Representative Weber.
Present in the room.
Representative Westrom.
Here in my legislative office.
Thank you. Representative Wilner.
I'm here in the 35th House District.
Thank you. Co-Chair Alvarado.
Present in the room.
Co-Chair Mosier.
Present in the room. Thank you. Turn my microphone back on. Thank you very much. We have established a quorum, although we are in interim, and we will go ahead with our first presentation. Senator Danny Carroll is here to discuss Child Care Center administrative regs. Oh, excuse me, we need to approve the minutes of our last. Okay, never mind. Please proceed. Please introduce yourself for the record.
Thank you, Madam Chair. My name is Danny Carroll, I'm the state senator from the 2nd District.
My name is Jennifer Washburn, and I'm the executive director of iKids Childhood Enrichment Center in Marshall County, Kentucky.
Madam Chair, we kept this to just a small group as far as providers intentionally. We want to leave plenty of time for questioning. I have about, 11 years now. One of the programs of the organization that I run is a early childhood education center. However, I will never know as much as this lady beside me knows, and she's always the one that I turn to when our organization is struggling or I have questions, and even looking at her to train some of my management staff in the future. So I have that much respect for her and the quality of services that her organization provides, and I think it is one of the best in the entire state, and I think she is one of the foremost experts in child care in the entire state, and it is an honor to be here with her today. Over the past year and a half through the pandemic, child care has fared fairly well through all of this. Our centers are already regulated in relation to cleaning and sanitizing, so a lot of the things that were asked of us, we already had in place, and our centers do an excellent job of taking care of their kids. We have gone through various types of regulations throughout the pandemic, probably the most recent set being the most controversial that we've dealt with the masking issues. But throughout the entire pandemic, we have focused on training of staff, cleaning and sanitizing, limiting access, doing regular assessments on our kids and our staff, and also the mask wearing aspect of what we do. I wish I had better numbers as far as breakdowns of cases within the child care industry, within the regulated industry. Still working on trying to get that information together so we know in a more accurate breakdown by age what we are facing in child care. I do know some numbers that I received this morning. To date, during the pandemic, there have been 1,019 regulated child care programs affected with positive cases. 1,309 of these cases were children ages infant through 13 or to 13, and then 1,379 of these cases are staff cases. A number specific to our center, we've had to close down probably 7 or 8 classes throughout this pandemic for quarantine. And of the kids who have been quarantined during those classroom closures, we have had 0 of those kids end up being positive for COVID-19. So we, without question, have found that our kids are more resilient, more resistant to COVID. Those numbers are rising, as we all are aware, with the new variant, and that is something that we face. Over recent weeks, I was tasked by Senate leadership to help come up with a piece of legislation to guide child care centers as we move forward in dealing with the pandemic. Over the last couple of weeks, I have spoken with numerous directors and owners throughout the state. I've spoken to medical professionals, I've done some reading, and I've sought feedback from parents. And we have made an effort to put together a bill that will allow the centers to continue to operate in a safe manner and an efficient manner, and a manner that will help to allow the development of our kids, which sometimes during this entire ordeal seems to have been overlooked. And we do need to make that more of a priority as we move forward. The bill that has been drafted has been based on previous regulations that were handed down by the cabinet, regulations that are still applicable today and where we are, and regulations that we have found to be effective. This bill is still open to input, open to change. I'm willing to listen, and I welcome the input from information that you all may have from your districts, from owners within your district, medical professionals, or whatever the case might be. So it is still very much a work in progress. However, our goal is to set a set of rules in place now that can allow some stability in the industry, so we know what we're going to be facing at least until January when we're back in session, that will allow our centers to continue to operate in an efficient and effective manner. At this point, I'm going to turn the floor over to Jennifer. And again, it is an honor to be here with her, and we will take questions once she completes her testimony. And thank you, Madam Chair.
Thank you. Members of the Joint Committee on Health, Welfare, and Family Services, I want to thank you, first of all, for giving me the opportunity to share my experience of what has worked and what has not worked over the past 18 months of this ongoing battle to mitigate COVID and all the effects in the child care industry. My name, as I said before, is Jennifer Washburn, and I am the owner, executive director of iKids Childhood Enrichment Center in Benton, Kentucky. I have a master's degree in counseling and am all but dissertation complete for a PhD in developmental psychology. My program has been in operation for over 20 years, has been NACE accredited for 15 of those 20 years, is 5-star rated by the Governor's Office for Early Childhood, and has never closed, even when child care centers were mandated to close in March of 2020 as we were granted LDC status. In 18 months, I have had 1 adult case of COVID in my space, and that was January of 2020 when a substitute teacher, a college student, worked for 2 hours on a Friday and tested positive on Sunday. We have had 0 student cases to date and have had no further teacher positives resulting in closure in our center. I've had the opportunity to speak to some from this committee before, and I am deeply thankful to be here again providing updates and painting a picture of where we have been, where we are, and where we still need to go. How has my program found success? Please know that we credit this to implementing with fidelity some very important health and safety practices, and this includes strict testing, strict temperature checks, masking of adults where our county is in the red or is mandated to do so, quarantining, sanitizing, and vaccinations of staff. What is working? In my center, we still conduct temperature checks at arrival and at all meal times. We all know of children who may arrive at the center fever-free, only to spike a temperature 4 hours later because likely they were administered Tylenol before arrival. We have found great success with continual temperature checks. It also helps the parents to understand that their child will be checked throughout the day, helping to motivate parents to not mask symptoms with medications. In my center, we have maintained the heightened cleaning and sanitization practices. Daily cleaning schedules that include full center sanitizing is important. This does come at a tremendous cost. With the current exponential rising of expenses childcare programs are enduring, unfortunately, this could prove to be a financial hardship to many families. Additionally, I currently have a vaccination rate of 100% in my 12 lead teachers, and of our 12 assistant teachers, only 4 are not vaccinated. Currently, all adults, including teachers and parents, are fully mask wearing while in our building. Families are invited into the building, however, are encouraged to drop the child off at the threshold of the classroom door and spend no more than 1 minute talking with the teacher at drop-off or pickup. We do encourage parent-teacher brief face-to-face communication so that quick contact can be maintained as important to family-child care connections. All parent communications that are requiring longer conversation is limited to telephone or Zoom, and all communication is sent digitally, and that's our go-to for family engagement. We have currently stopped our in-person family engagement activities while our county is in the red. We have strict quarantine guidelines. First and foremost, if anyone in the household is in quarantine, even if they are negative, the child or children may not attend our program. Second, if anyone in the household is waiting for a COVID result, the child may not attend our program. The same rules are strictly enforced for staff, including when a staff complains of not feeling well or shows any symptom of COVID. They must submit to having a COVID test and quarantine until the results have been returned. While this is an absolute hardship to our facility, I am desperately low on staff. It is a key component of our current success rate. What is not working? Under the current regulations, child care centers are required to mask children 24 months and older. We are struggling with masking our 2- and 3-year-olds. I compare my daily experience of masking 2-year-olds to trying to keep a mask on a cat. If you have a cat, go put a mask on it, and good luck. We, iKids, are NACI accredited. We are a 5-star child care facility. Because of this, we chose to have a child-to-caregiver ratio in our 2-year-old classroom of 1 caregiver to 7 children. The state says we can have 1 caregiver to 10 children. Because of COVID, we have an enrollment of 10 2-year-olds. So I have 2 teachers for 10 2-year-olds. That's double the teachers the state suggests for that age group. When the mask mandate and emergency regulation was created to help with the task of mask teaching, which is what we call it, 2-year-olds, in addition to potty training, that's also going along simultaneously, I added 2 assistant teachers to the 2-year-old class. That's 10 children and 4 teachers. So let me tell you how that's gone. On any given day, you have 2-year-old children throwing their mask in the trash, or on the floor, or chewing on their mask, or picking up another child's mask and chewing on that mask. Teachers are continually reminding toddlers, mask on face, where is your mask? Mask on face. Teachers are continually, even 3 to 4 weeks later, struggling with keeping the masks on the face of our toddlers, of our 2-year-olds. Children 24 to 36 months do not have the fine motor skills needed to put a face mask on their face. They can't even hold a pencil. They do what's called this grasp, and it is hard to carry a mask onto your face when you don't have the proper grasp. They can't put a mask on their face or fix it without proper assistance from an adult. And please remember, when a teacher touches a mask, they must immediately sanitize their hands between each friend. That's a daunting task. Children 24 to 36 months are in prime developmental stage for language development. To date, there are no long-term scientifically based studies on the effects of mask wearing in this age to language development. Further, watching a child 24 to 36 months of age wearing a mask, trying to look down to play with the toy, visual tracking, and you can experiment with your own mask. You will see this is the time the child pulls down the mask. Why? It's blocking their visual field. They can't see. Children with small faces, as they tilt their heads, are blocked from seeing the item with which they're trying to play because of their mask, resulting in it taking off, resulting in the teacher saying, mask on face, resulting in the teacher putting the mask back on face, and then washing their hands yet again. 3-year-old children, while improving, are still not more than 60% proficient in our space at keeping the mask fully covering the nose. They also do enjoy chewing on the mask, and they're struggling still with communicating, articulating their needs and wants in an intelligible language with the mask on. Think of the teacher in Charlie Brown, and think of a bunch of 3-year-olds sounding like, I have to go to the bathroom. That's a really hard thing to do in a class of 10 3-year-olds. Currently, the emergency regulation does not allow for children who are not developmentally able to not wear a mask. I had one parent of a child who has the diagnosis of a speech delay, and she requested that her child not wear a mask. He is 2, and he turns 3 in 2 weeks. The family physician notified her that they could only write such a request if the child were diagnosed on the autism spectrum. Recall, our class sizes are significantly lower than what the state allows. Our 3 and 4s are a cohort of 10 children and 1 teacher. The smaller class size may be a contributing factor for our success. However, the majority of programs cannot financially support lower class ratios. What do we need? Child care programs must be up to date on quarantine recommendations as stated by local health departments. Each program must have access to a health department liaison with whom they can speak immediately. Many providers still have to go through the same health department number everyone else calls, get put into a voicemail, and may not get a call back for several days. This makes them have unfortunate opportunities to make huge errors when they are allowing children or staff to return to care because they lack immediate access to their local health department for best practice support. We need teachers. The staffing challenges are exhausting. Without the investment that has been made to childcare to date through the CARES and CRISA relief money, I can definitely say that my program would not be open. We are a NACE accredited, high-quality, 5-star program, and the investment that has been made to date, the stipends that have been provided, have been the lifeblood of our program. I've been able to raise teacher pay to $11 per hour, and we're on target to get to $13 by November 1st. Still not quite as high as Chick-fil-A. When that money is no longer available, when that investment is taken away, parents will be asked to pay more, and I raised my rates on August 1st of this year. As I've said before, we're not in this for the financial reward. We chose this field because we are compassionate and are called to serve our youngest citizens and the families who love them. We have been and we continue to be essential. When my county schools chose to close this Friday, meaning tomorrow, and next Tuesday to address the rise in COVID and the lack of substitutes, my phone's lit up. I have 42 school-age children at the 2 after-school sites, and I only have room for 14. I had to deny care for 28 children. Currently, I'm not operating at 100% capacity, and not because I don't have the children. My waiting list is very long. It's because I can't find staff. We're all experiencing COVID fatigue. We're all experiencing compassion fatigue. It becomes more and more difficult to find teachers who are willing and able to nurture this population in our industry. We can care for an individual child 8 to 11 hours each day, 5 days a week. That's more time spent with us, waking hours, than they spend with their parent. and it has become increasingly more and more difficult to be the enforcer, especially of our 2s and 3s, of mask wearing. Again, I do appreciate the opportunity to share what has worked for my program. Please understand, I have chosen to be a NACE accredited high quality center. I have had access and success because of the resources afforded me, thanks to the relationships, accreditation, and procedures already in place of a high quality center. This may not be the norm for other child care programs. What I can attest to for all of us is we all need continued investment. We all need to be included in the conversation as to what works and as to what has been an absolute hardship for our programs. And we all need to be respected as essential as the essential industry that we truly are. I do thank you for listening and for including me in this conversation.
Madam Chair, just a couple other issues that I want to address. And first I want to mention that worked fairly extensively with Dr. Sarah Vanover, the Director of Child Care in the state. And she does an excellent job, and she is always very open and providing guidance. And I think we are fortunate as a state to have her in that position. Unfortunately, she was not able to be here today to testify. A couple other issues that we notice from time to time, as Jennifer said, the inconsistency from the health departments is very troubling at times, and it often depends on who you get on the phone as to what guidance that you receive. That guidance often contradicts with guidance that you receive from physicians. There is no set pattern that you can follow. You get different recommendations or different notes from doctors, and oftentimes you're left trying to interpret what to do to be consistent yourself. I would also at some point like to have the discussion on the test and stay option that we discussed yesterday in Chairman Wise in Education Committee that some of the school systems are using. If this might possibly be an option for child care, if parents opt in to do that rather than quarantining. If they have been exposed in a classroom, having the option to test the child daily. And as long as the child tests negative, the child is able to remain in the early childhood education center. That's something that I think we can look at. And I'll leave it at that. And Madam Chair, we can open to questions if that be your desire.
Okay, thank you very much, Senator Carroll. I really appreciate all of your work through the pandemic and beyond, really. And I know that you're taking a long, hard look at the regs, which were relaxed, and looking to see what would actually create stability. Thank you very much, Ms. Washburn, for being here and for all of your work through the pandemic. I know that this has not been easy. Just paying attention to what's developmentally appropriate for your children and working with parents is critical. I think that throughout this pandemic, we've been given directives, and we certainly know how to keep our littlest ones safe and each other safe. And we really need to allow our businesses to put those in place and decide with their families what's best for their centers. So I look forward to seeing what we need to continue and work on. We do have a couple of questions. I'm going to go to Representative Fleming first.
Thank you, Madam Chair. Senator, thank you very much for bringing your guest here. Ms. Washburn, thank you very much for your testimony and giving us a description of what's going on in your environment, because I know it's very difficult to deal with, particularly with the works and so forth. So I have like two sort of disjointed questions, but there's a method to my madness.
Okay.
And I'm trying to do some other research. So what are your revenue sources?
What are my revenue sources?
Yeah, and roughly percentages.
Okay, so prior to pandemic, my revenue source was parent tuition, family tuition.
Private pay.
Private
okay.
pay, that is correct. With pandemic, we now have been able to add the stipend money through the CARES Act and the CRISA money. So that is in addition to parent pay.
Okay. Second, off the wall question is competitive pay. What's in your area? you said you got a workforce issue and so forth. What's the competitive pay, roughly speaking, that you have versus what you're up against?
So currently, our goal is to get, and we will be at $13 an hour by November 1st. And the local Chick-fil-A down the road starts at 12 to 15. Does that answer your question?
Yes, ma'am, it does.
And my teachers, being an accredited facility, our teachers have their degrees, early childhood credentials, CDAs. Many of them have been, what happens is we become a stepping stone. They work through my facility as graduate students or as people getting their CDAs, and then just as soon as a position is available within the schools, they move into those higher paying, benefit-driven positions within those spaces.
Okay. Are you nonprofit or profit?
Profit.
Okay.
Just me.
Okay. And I imagine your margins are pretty thin.
Yeah.
One more question, Madam Chair, and it goes back to my friend Senator Wise, who had a good, robust discussion yesterday in the Education Committee. In the testimony, had test and stay. Are you familiar with that? And then is that type of environment or application applicable into your environment? And then I don't know, I'm trying to think on Senator Carroll how to incorporate that into the regulations, if at all possible.
I would think for me, I would have to do additional research on that. Some questions I would have would be between if a test was given at 8 a.m. For example, let me say this. If a child comes into my facility at 7 a.m. and I take a temperature check and their temperature is normal, we know that fever-reducing medication can typically wear off within 4 to 6 hours. So that's why we do the additional temperature checks at lunch, breakfast, lunch, and snack. So, and if you have a child, oftentimes they will spike a temp at 3 o'clock in the afternoon. Somehow. That's the magic fever hour. So we are then checking them, testing them for fever throughout the day. So my question for test and stay would be, for my facility, how long is that negative test viable? 20 minutes, 5 hours, 6 days? And the reason I ask this is, that student that subbed for me for 2 hours on that Friday in 2020 did not show symptoms until Sunday and got tested on that Sunday. At that time, the health department told us there was a 48-hour contagion window where she was contagious and you would not have known. So I had to close that classroom because of the Friday of 2 hours. Does that make sense?
Yes,
Those would be
it does.
those questions.
Yep. Thank you.
To give you an idea of what we face, we have spent hours watching cameras to determine if a staff member was within 6 feet of another person for 15 minutes within an 8-hour day. I mean, that's how far this has gone in trying to comply and really understanding what we're doing. And again, when we've had to close down classrooms, we haven't had children that ended up being positive. Our situation would be a little bit different. We have nursing staff on site with one of our other programs, so we're able to use nursing staff to help assess children throughout the day. But I think it's something that we could look at, and it obviously be an opt-in for families. I wish we had better data for childcare as far as the number of children who ended up in hospitals or in ICUs. Still trying to get that. I don't think it's there, but I wish we did have it, and I think it would help us to better plan as we move forward. But the things that Jennifer said, it has been a struggle. Staffing in our center, our staffing's getting better. We've hired 5 people within the last 2 weeks. I think we're still maybe 2 or 3 short, and we're a larger center. We have when we're full capacity with our kids, about 120 in our early childhood education, and then 30 to 35 in our prescribed pediatric extended care program, and those are all under the same roof. So staffing has gotten better. We've gone through the same pay issues. We just raised our pay up pretty close to what she's doing, and we took another course to not obligate our organization to a $15 an hour when funding is going to go away in a couple years. We decided to give conservative raises and then do bonuses as we move forward, and that's worked well for us. And so the struggles are pretty consistent with what we faced.
Okay, thank you.
Okay. Thank you. And I would agree that the test and stay is it's a good idea. It sounds like a good idea, but you're right. It does not address the incubation period, and it really doesn't address those patients or folks who might test positive 3 months down the road. So there's some work to be done. Senator Berg.
Thank you for a wonderful, wonderful presentation. I have two quick questions. At what age are you able to reasonably keep a mask on a child without hurting that child's development and without having to have somebody struggle with that child continuously?
Probably be, 18 maybe?
I have many adults that are still struggling with that issue right now as we speak. Within our space, I'll answer your question in two definitive ways. What age will the child keep the mask on their face? In our space, typically, most 85% of our 4-year-olds will keep it on their face. But that could mean that it's here, and we're saying, cover your nose. Remember, the COVID bugs live in your nose, and when you sneeze, you send them flying. And when they fly, they infect your friends. So all day long, we are a Sesame Street commercial. So yes, keeping it on their face and having the ability, about 85% of 4-year-olds have now, remember, they're starting to write their name and get that pencil grasp beautifully. So that same pencil grasp can pinch this to my ear. So they're starting to be able to do those things developmentally 4 as you track into 5. The question I can't answer that you asked, because it's simply a new and evolving thing, is what are the consequences to development when we are masking our children now for 18 months? I don't know yet. And so we have to, at this point, choose what's safer and what we can do. And I can tell you it's not safe for a 2-year-old to pick up someone else's 2-year-old mask. And if you're curious, just open it up and look at the inside. A female, as you think that your makeup's on your mask, imagine snot. And then another child picks it up and puts it in their mouth. That's not healthy. So I hope that answered your question.
I think you did, and thank you very much. And then, if I may have a follow-up question, you stated that 100% of your full-time staff is vaccinated.
That is correct.
How did you achieve that?
They are good staff that wanted to do what they felt was right. Our conversation has been around, our children can't get vaccinated. We are a compassionate field, a compassionate group of people that want to do what is best to protect our children. And so that means we have to put on our protections, our armor, to keep ourselves safe so that our children can then be safe. And so the staff are 100% vaccinated, the full-time staff. Of the 12 assistants, 4 are not yet vaccinated.
I would just like to say that if we could put you on TV, I'm serious, with explaining exactly how you explain to your 4-year-olds why you have to cover your nose and what this virus does. This is exactly what people in the state need to understand. And your answer to why your staff is vaccinated, because you care and you're taking care of other people and you know it's important. If we could put your message statewide and let people's hearts listen to it, I think we could take care of this. Thank you so much. And I wish to God that when my children were young and I needed full-time daycare, there was somebody like you that I could have relied on. Thank you for being here.
Thank you.
And I did have her available. She was my child's first teacher, daycare center, and I knew we were at the right place. When I walked in the door, my daughter was walking with a walker, and the first thing she said was, "How do I need to change this building for your daughter?" And been sold ever since then. A couple things I want to add. The development issue that we have struggled with has been in place ever since our staff have been required to wear masks. Over the past year, we have seen behavioral issues like we have never seen in the 11 years that I've been in it at our center. And to the point that I started calling other centers because I thought we were doing something wrong. And I found out that this was across the state that these issues were occurring. So that's the development part of it, not only with the children, but with the staff also that we need to consider. And as we talk about mask issues, which is at the center of the discussions with childcare, it's important to remember we want people to wear masks. We don't know the level of effectiveness for a mask, but we do know that whatever level there is, they have to be worn properly to get that protection. You can say that at 2 and above within a child care center can wear a mask safely, but do they really accomplish anything is the question. And I think without question for the younger 2, 3, there is no value there. There is no protection there because of the things that Jennifer mentioned. And I think we have to consider that. And even for 4, 5-year-olds and 6-year-olds, that protection is still minimal. That's the reality of day to day. And I understand what medical folks say, and I understand the different opinions, but the reality of being in a center every day, the children simply aren't wearing them properly, and they are exposed throughout the day. It's counterintuitive to require a kid to wear a mask, but then you take it off and you're allowed to sit side by side with your friends to eat lunch. And then you lay down where you're in close proximity without a mask. So where is the value? And if it truly was a benefit to protecting the kids, absolutely. But we don't know in best case scenario, in the incidents with our children are far from best case scenario. I'm sorry.
Okay.
Thank you, Madam Chair.
Thank you, Senator. Senator Alvarado.
Yeah, just really briefly on that issue, and we mentioned this in a previous committee hearing with regulations. World Health Organization has an opinion on children under the age of 5. A lot of other countries have established, have had Delta variant longer than we have. They have recommendations. They say emphatically under the age of 5, children should not be wearing masks. Ages 6 to 11, depending on local input from teachers, from parents in their communities, 12 and up they recommend, but under the age of 5, they say they shouldn't for the sake of really psychosocial and their development as well. So I just wanted to throw that out there.
And I'd received many comments in asking for feedback about following the science. And the response is, which science? And the bill that we're developing does follow the WHO guidelines, and it will give local control to these decisions. And that's kind of the direction we're heading in as far as masks. And I feel it very important that parents have some input and say in this, because I think in the case of the younger children, it is more of a personal issue with those kids, and with the controversy and the mixed messages that are out. I think it's crucial that parents have a significant role in making these decisions for their child. There is no one who's going to watch out for the best interest of a child more than a parent. And I say that in most cases. I know there are exceptions there, and the centers are always watching out for the best interests of children. And I have no doubts that with the local control that we're proposing, that the quality care and protection for our kids will remain in place, and our centers will continue to do what they've always done.
Okay, thank you. Representative Tate.
Thank you, Madam Chair, and thank you very much for this testimony. This is very enlightening. So I've got one short question and a longer question. So one is what is the average age of your staff? And that was before COVID and now after COVID. And then also, you've talked a little bit about the developmental age and the consequences of the issues with children wearing masks. But as a grandmother and a parent, I understand that children are they watch your facial expressions, etc. So what is the impact that you've seen from the adults wearing the mask also with these small children?
Certainly. To answer your first question, in our facility, our age range the gamut. Our assistant teachers are going to be our younger teachers, but in my facility specifically, our ages run the gamut of who's caring for our children. And it's simply because we have teachers who have their CDAs, who have their associates, who have their bachelor's degrees, and who have committed themselves to this field out of their passion. So I can't speak to that as being the case for all child care centers, but I can speak to what's in mine. The second question you have is, yes, you beautifully pointed out that mask wearing in children, we're still trying to figure out what developmentally is occurring. We're starting and we see an increase in behaviors such as tantrums, language delays, biting, potty regression, tearing masks off of each other's faces, aggression in especially that 2 and 3 year old age. We have seen that increase while masks have been being requested of that age. Prior to that, however, we had a long stint in childcare where we were requested as adults to wear masks for a very long time. And then we had a break where we didn't. And so to answer your question, what has been the difference? When the teachers had their masks on the entire time, in our younger children, we again were seeing an increase in those aggressive behaviors because when you started to speak, Representative Tate, your voice is coming from many places. So I wasn't sure where you were. And so I'm looking around going, okay, and then this nice gentleman with the camera was right in the way. So, but I'm glad you moved. Thank you so much. But I'm an adult and I'm using visual tracking and my ability to hear to locate you. By now, you've probably told me 5 times, don't stand on the table, but I'm still standing on the table because you might not be talking to me. So that is very hard for our younger children because they have to visually track and auditory track where you are and what you're saying to know, are you talking to me? And also, if you're familiar with commercials, if you listen to commercials now, the people will repeat their phone number 3 times so you remember it in your head. Most teachers will give a command 3 times before the child can respond. But if the child can understand what's being said, it's taking longer for the response and it's taking longer to get the change in behavior. So that is something that we are seeing with our younger children. When the masks came off, we saw an improvement. But in my space, when our county got to the red, the masks had to go back on. Now, can we do that for 3 more years? That's going to be rough. And if you want to be a speech language pathologist right now, that is the industry to get into because you will have a lot of business. But that's sad. So I have to articulate, you have to see my mouth. As an early childhood person, I have to be Grover and Elmo and use an entire face in order to get you to look at me. There are studies on infants and masking and attachment. There are studies on that, but it doesn't go much beyond that for 2 and 3 year olds because how long have we had to be doing this? And how many studies are there? So again, to answer your question, it is harder, yes, when adults have to wear them. But I will say there are times when it's necessary that we do. And then I put it back on parents too. When you, as a beautiful grandmother, have your grandchildren, it becomes an additional responsibility on you to engage with your face because they have you for your full face, moms and dads too. And I know as a society, we're also now really battling technoference. And that's in the way, meaning your phones and devices and TVs are what's entertaining our children. And so the early childhood professional is that person, that maskless person that is helping language development, helping with expression, helping with attachment. And when we are barriered from that for a long time, there will be some effects that I'm slightly worried about.
Okay, thank you so much. This is so interesting, and you are clearly so knowledgeable about this. But we have a long agenda, so I'm going to allow a few more questions. But if you could keep them brief, that would be great. Representative Sheldon.
There's a reason she said that right before she called on me.
Uh-oh.
Thank you very, very much. I appreciate that, Senator Carroll. Thank you for putting this together. I will narrow this down real quickly. How about, sounds to me like the younger children are going to be an issue that we probably, that owners should be allowed to make those decisions of those child care centers, and I'd be all for that. But one thing we haven't talked about, I'd like to maybe suggest that, and maybe we have, I just missed it, but relaxing some of the quarantining rules may also be a big part of what I think maybe Senator Carroll would want to look at. Test and Stay kind of does that. I'm in the same boat as the rest of these folks. I don't think that that's ultimately an answer, but maybe when somebody does test positive, as opposed to, like, for instance, it's 6 foot if no mask, right? It's 3 foot if we have a mask. I would maybe even propose that if they test positive, that nobody would go to quarantine unless they showed symptoms or they tested positive. So other states have tried that, and I think that keeps we're hearing that 90% plus of the children that are quarantined are not coming out positive. So why wouldn't we relax the quarantining method? And because the idea is to keep these kids in childcare, and because it starts with you. You were talking about your staffing issues. Well, I guess childcare has got staffing issues. Then healthcare, education, small business. This is all across our state, and so we're not going to legislate an answer to all that. I can assure you that we won't legislate the virus away. What we can do, and I think what we should be doing, is giving you the tools and giving you support at our level. I think getting involved in us handing down our the science we want to believe in, let's put it that way, is probably not the case. We should leave it with the child care owners, and I trust you completely, and I'm sure that you'll do a good job in handing out these. But I do think quarantining and trying to change some of those rules around quarantining, because a lot of people thought, well, when they went to a mask, their quarantine number was cut in half. The truth is, the quarantine number was cut in half because they went from 6 foot to 3 foot, and they learned how to rotate the kids every 20 minutes. I mean, they're just learning how to get around that. So I would really strongly suggest that we try to look at those quarantine rules to keep people in school. And thank you very much.
Thank you, Representative Dotson.
Thank you, Madam Chair. Thank you, Senator Carroll and Ms. Washburn, for coming today. My wife and myself have owned a daycare for over 20 years, so I can shout a big old amen to everything you said, to attest to all the hurdles and challenges that you faced, we faced as well. One of the things that we faced here as of late, in 18 months, I think we've had one child test positive. And with all the precautions you can take, it can happen to anybody. So doing our due diligence and asking and telling the parent that we had to, keep the child away from the daycare for a specific period of time, she takes out all 4 of her children and goes to a daycare down the road. Where is the consistency that, locally, that another daycare or some sort of database to where that an owner such as yourself can tap into just to make sure those things are kosher? If you take a child, have they been excused somewhere else for another reason? And I find that to be a challenge because I think it's happened several times in other cases as well. And I just kind of want your input on that.
So let me be clear. You're asking, would it be helpful for child care centers to be able to cross-communicate, to share communication with each other for families who may leave from one space and come to another? Yes, I would hope that within a community, especially given the circumstances we're in, child care centers would reach across the divide and talk to one another to ask those questions without having to come up with a system. For example, our schools are closed tomorrow and Tuesday. And so I had to make sure that the children that were actually able to get in the lottery system that we had are not children that are supposed to be quarantining.
Right.
And so I had to reach across and contact school and say, hey, I know you can't give me much, but let's figure out whose classroom is quarantined and I can figure out who's in that classroom. It takes more detective work on my part. Yes. Is there a simpler way? Maybe. Could that be helpful? Possibly. I think that some of those hurdles, though, can be helping one another. But I do think it's important to communicate because, yes, families hop. Families skip and jump to get their family's need met.
But would you consider that a HIPAA violation?
I'd have to go into the HIPAA rules. The school can't tell me who's been asked to quarantine and who is positive and who's negative at all. But I can ask you at your center, was Johnny enrolled there last week? And just like when you fill out a list of places that you've been before, meaning have you been at another center? That's one of the questions we ask on our enrollment form. Has your child been in any other child care facilities? They can lie, of course. Mm-hmm. So when that happens, temperature checks, wellness checks, your due diligence on making sure these kiddos are okay when they come into your space, that's going to be equally important. The same kid can get sick when they go to Awanas on Wednesday night. and none of them mask at Sunday school. So it's not just going from center to center. It's what are they doing in their off time at gymnastics and Awanas and Sunday school and all the other things.
Right.
And then I'm building a moat to keep the sickness and the COVID bugs out of my space.
Right. And one follow-up, Madam Chair.
Very quickly, I mean, we've got, we have a lot of people.
Well, I just want to say this because we're being watched around the state. Now, in your facility, do you mandate vaccination for your employees?
No.
Okay. And the reason I'm saying that because I don't want anyone to think that someone doesn't care if they've not taken the vaccine as of yet. Because we have centers around the state. We have people who are considering it, that are weighing the options out. So I just want people to know that we don't consider you inconsiderate by not taking the vaccine at this time.
Correct. And that's how my 4 staff, they're just not there yet.
Thank you. Okay, last question will go to Representative Bentley. One question, please.
Thank you, Madam Chair Lady. Thank you, Senator, and thank you, ma'am, for coming today and a good presentation. You know, back before the Civil War, when we had chicken pox, we would gather all the girls together for the aesthetic value and have them sleep over. For we knew that chicken pox was spread somehow, and we later found it was respiratory droplets. Most viruses are 22.5 micrometers in size. So there is some concern about if a mask really works or not. The recovery rate under 18 of children who get COVID is 99.998%. Let me say it again, 99.998%. So there are questions about masks that we've never asked. If they get loaded with bacteria and pathogens, are they a source of transmission later on? Do they become a retainer of that pathogen? A pathogen is any organism that causes disease, for people who don't know. Are large droplets captured by those masks and later evaporate to let that pathogen stay there? And can the virus escape an evaporating droplet? We do not know any of these things. Let me go on with things we don't know. Are there dangers of bacterial growth on a used or a loaded mask? How do pathogens, droplets, interact with our environment? Environmental dust or aerosols? What are the long-term effects, such as headaches arising from impeded breathing? So there's all these consequences. There's social consequences, which you just talked about, psychological consequences. I think I had one of those with my brother holding a pillow over my head when I was younger. Environmental consequences of mass manufacturing and disposal. And my last, do they shed fibers? Do they cause COPD? But usually smoking causes COPD. Are they harmful to if they are inhaled? Because most of the masks are made in China, if you look at them. So are we guaranteeing that these masks are pure? And when you get really down to the studies, the transmission of droplets is due to the humidity in the air. It's not the mask.
Thank you. I think that was a lot of questions rolled into one. Thank you very much. All right, we're going to move on.
I'm not done, but I'll respect your chair.
Well, thank you. I think we do understand your point, Representative.
The public doesn't. And I represent 40,000 people need to know that.
All right, well, I'll give you a few more seconds while
that's fine.
Senator
I respect your
Alvarado.
chair. That's fine.
Okay, thank you. All right, our next presentation will be, thank you so much for all of this and for putting up with all of our questions. I really appreciate all of your work. Our next presentation is on COVID-19 immunity, and we have Senator Alvarado and Dr. Joseph McConnell coming to the table. Please go ahead and introduce yourselves for the record and proceed with your testimony.
Thank you, Madam Chair, and thank you all for your kind attention. I know we've got a lot of ground to cover. We could probably be here for the entire day, but I wanted to have some remarks as we're trying to find a path forward as to how we're going to handle things. And I want to begin with a few remarks. In the practice of medicine, doctors, really by the nature of their training and their experience, want nothing more than to get to the root of a problem. And it can be frustrating for medical professionals to watch how the world of politics can hinder public health. And that is certainly true for me. And the problem of politicization of public health issues and even counterproductive measures by officials has never been more evident than it has been for this past year and a half. Through the past 18 months, medical professionals on the front lines have been steadfast in addressing a public health crisis, and they've encouraged and promoted the safety and efficacy of vaccinations. They have personally treated those who become ill. It's really not politics for them. And however, government bureaucrats, officials, talking heads have made matters more challenging in their consistently inconsistent guidance and contradictory information at times, poor messaging, arbitrary edicts and narratives that have caused many in the public to view COVID-19 politically instead of the health issue that it is. In fact, while I was just giving testimony, I had somebody email me just as we were speaking, and I quote something from the World Health Organization because they have a different political view, thinking, well, I'm just presenting what is being presented by a lot of physicians internationally. I hope that public officials, including all of us, can start to recognize when our messaging has reached the point of ineffectiveness. And Kentuckians and Americans really don't need to be lectured to. They need to be part of the conversation, and their concerns need to be heard, much like they would be in a conversation with a good doctor who would guide and recommend the course of action for a patient. In the past 2 weeks, I've been very busy. I've had a chance to call and speak to our hospitals, our physicians, nurses, some of our licensing boards, our chief medical officers for our hospital systems to get some consensus and some ideas on what needs to be done moving forward. I want to remind the members that we are a state that has an urban area and rural area. That divide is real. It continues to be real, particularly in this space. And I think when we started this journey of COVID-19, there was a lot of unknown. We've learned a lot. I think what we're looking at now is prevention as one side of things and treatment as another once people get diagnosed. And to understand that we're not experts in COVID. This is a novel virus. It's a new virus. So we're learning as we go. Fortunately, we've got some experience from other viruses in the past, but we continue to learn things as we move forward. I remind people that medicine is not 100%. People think that everything is somehow black and white and there's true and false and a lot of those things. Medicine has got a lot of art to it too. And I think anyone who provides care to patients know that we have to apply what's important for that patient. And that in medicine, sometimes what is science is what we know at the moment. And that we learn things as we go. What might be true today may not be true in 6 months or a year or in 10 years. And again, people think that we're very fancy when it comes to healthcare. We're fancier than we were when the Spanish flu hit 100 years ago, but we're still not all that fancy when it comes to other diagnoses and treatment. Again, I compare things to the Spanish flu, which we talk about outbreaks and how we handled things back then. We didn't have concentrated oxygen at that time. We didn't have nebulizer treatments, monoclonal antibodies, remdesivir, steroids, things that you have all heard about that people get treated with. So we've come a long way, but still have a long way to go. And again, I remind people that we're talking about viruses here. We don't have a cure for the common cold yet. That's been around since the beginning of time, and that we're still learning as we go. One of the things I wanted to talk about, and I have Dr. McConnell here, is we continue to struggle in terms of getting people vaccinated. And I would encourage those who are watching, if you have not gotten vaccinated, please go out and get vaccinated. If you don't want to take my word for it, or go talk to your doctor, your medical professional, and have a discussion with them. We got about 48 to 49% of our state fully vaccinated and about 57% with at least one dose. And we've had a lot of attempts to encourage people to get vaccinated, things like lotteries and giveaways. But let's remember that we're not trying to sell a car here. This is a recommendation by government and, more importantly, by healthcare providers for a potentially life-saving preventative measure. There are many things that doctors recommend to help save our lives. Influenza shots, which only about half of our population takes every year. And we have to remind people that children die every year from influenza. Adults, young adults, die from influenza every year. Diabetes management, exercise, proper diet, tobacco cessation costs 8,900 lives in this state every year. And people ignore those recommendations by our doctors every day. And physicians are not successful in getting people to comply with their recommendations by forcing patients to do what they don't want to do. It's done with education and reassurance and with respect for patients' abilities to decide. We have an ethical obligation, at least by the American Medical Association, that doctors do, to respect patients when they don't sometimes agree with us, but we don't demean them or call them names or say things about them that are negative. We try to ask what the problem is, reassure them, provide more education, and hope that our influence provides them a better path in the decision they're going to make. COVID really is no different at this point. And I would encourage all of us, let's stop judging someone else on whether or not they're wearing a mask, or whether they're not wearing a mask, whether they've been vaccinated or not vaccinated. Let's not make judgments about one another. And I would ask that from all of us and from the people that are out there watching as well. The first topic that I'd like for the committee to contemplate is the topic of immunization status. I think a lot of patients have not been vaccinated, but many have had the virus, perhaps without knowing, and therefore may have a natural immunity for now. The CDC and Israeli studies have also confirmed that many people that have had a natural infection do, in fact, typically have a stronger antibody response that is higher in the amount of antibody and longer in response than a vaccination. At least that's what we know, again, for now. And I believe that patients can go and have antibody levels checked at labs. Right now, people can do that, but we get what's called a qualitative, just to know if you've got antibodies present. I think Dr. McConnell is going to address a bit more of that. And we talk about people that are vaccinated and unvaccinated. I think the discussion needs to start being about immunized and not immunized. We heard about chickenpox earlier. If a 6-month-old came to my office and had chickenpox, hopefully they don't have a bad outcome from it. But once they have it, they have an immune response to that. They're due for that vaccine at 1 year of age. If they've already had it, there's not really a need to give them that vaccination necessarily at a year of age. But again, many countries are starting to recognize not only people being vaccinated, but also having proof of immunity. If they've already got the infection, they have proof of an adequate antibody level. And again, I've asked Dr. Joseph McConnell here to come and provide a presentation. We met not that long ago, really to talk about labs and opportunity for lab work here in the state. But he's a scientist, works for a company that he's going to introduce here in a moment, Aditex, which was established by Dr. Leonard Bailey, a former professor of mine at Loma Linda University, where I got my medical degree, who has passed away, who did baboon heart transplants back in the 1980s and had to deal with immunology after a transplant and established a company to study a lot of these things. They're doing a lot of quantitative antibody testing to help guide practitioners on the proper course of action. And I think his presentation may help explain how and why certain patients are having repeat COVID infections or why certain vaccinated patients contract COVID after vaccination. So with that, Dr. McConnell, if you want to introduce yourself and begin your testimony.
Yeah, thank you very much, Dr. Alvarado. It's a pleasure to be here, Madam Chairman, and the rest of the group. It's a pleasure to be here. I am Dr. Joe McConnell, a PhD. My background is that I was Director of Cardiovascular Laboratory Medicine at the Mayo Clinic for, actually, let me start with my current title. I'm the Senior VP of Laboratory Medicine for Aditex Therapeutics. I previously was at the Mayo Clinic as Director of Cardiovascular Laboratory Medicine, and I was also a Director of the Clinical and Translational Research Facility at the Mayo Clinic, where we really looked at a lot of different biomarkers for various diseases and disease states, and we tried to translate them from research into clinical practice. And that's what we're looking to do here as well today. And that's why I'm so excited. Whoop, can everybody hear me okay? Sorry about that. That's why I was excited to meet the folks at Aditex Therapeutics. Since they have, Aditex Therapeutics is an immune, really is involved in developing the health and understanding the health of an individual's immune system. And they have both a reprogramming division and a monitoring division. With my laboratory medicine background, I'm more related to the monitoring side, but the reprogramming division is very exciting, developed between Stanford University and Loma Linda University, as Dr. Alvarado mentioned, and their technology is apoptotic DNA immunotherapy, which results in immune tolerance rather than immune suppression. So you're really actually able to do things like organ transplants and fight autoimmune diseases, et cetera, by tolerizing the immune system rather than suppressing. So you keep the rest of the immune system functioning while you allow things like organ transplants, et cetera, to be done. Very, very exciting. The monitoring division is going to be looking at developing companion diagnostics for all of those particular technologies. And of course, with the pandemic that's been going on right now and the immune system status, it made very, very good sense to start out with COVID-19 testing. So technologies that were developed at Stanford and Loma Linda University were licensed by Aditex, and we've been bringing them, translating those technologies into clinical practice as we go through. And really, we're looking at monitoring immune status. And I think Dr. Alvarado already covered a lot of my opening statements, but it really is about identifying vulnerable individuals in the COVID state. What is their immune status, particularly related to COVID-19? I've got a lot of slides, and I know we don't have a lot of time here, and so I'm going to skip through multiple of the slides, but just to show you that we spend a lot of time, and we do that in all times. In order to bring a test into clinical practice, it has to be very robust and withstand multiple tests to make sure that we're always going to get the right result for any individual patient that's in front of us. And so we did all the things like we have a very the technology is flow cytometry, which is a technical, very technical piece of instrumentation. We've got to make sure that all the instruments work correctly together and give you the same results. We've got to do things like establish the linearity, et cetera. And we really need to know what is the sensitivity and the specificity that is the positive predictive agreement and the negative predictive agreement. The technology that we have, flow cytometry, allows us to do a multiplex technology, so we can measure many antibodies to many antigens at one time. And what we've done is develop that technology at Aditext. So we have 3 locations. I'm going to skip through this a little bit, and we do really want to get onto identifying in an individual what is their immune status related to COVID-19 so that they can make the right decisions for themselves. Sorry if I'm drifting away from the microphone. I'm trying to reach over here and advance the slides at the same time. And as I said, it's a multiplex methodology. We have 9 different analytes, 3 different isotypes of IgG, IgA, and IgM to 3 different SARS-CoV-2 antigens. And then what's really important is that we have a method which you developed for neutralizing antibodies. Those are the antibodies that will bind to the receptor binding domain of SARS-CoV-2 and inhibit it from actually entering the host cell or the human cell and then beginning to replicate and to shed, et cetera. And then we have a proprietary algorithm which allows us to really look at all of the results and provide the best possible interpretation for any particular individual. This is, I'll just spend just a touch of time here. This is a diagram of a SARS-CoV-2 virus, and you can see on the outside you have the spike protein. That's where all of the interest is. You also have many other proteins like the receptor binding domain, which is a part of the spike protein. And then we have S1 and S2 subunits, E proteins. And then on the inside, we have this nucleocapsid protein. The reason I'm taking just a little bit of time to talk about this is all of the vaccines which are out there are vaccines to the spike protein only. The mRNA-related vaccines are vaccines to the spike protein only. And so you will only get an antibody response to the spike protein. You won't, with a vaccine, you won't get a response to the nucleocapsid protein with a vaccine. If you actually are exposed to the virus, then you will see all of those various antigens that are on the surface and in the internal workings of the SARS-CoV-2, and you'll develop antibodies to all of those things. So like the S2 subunit, the E protein, which is the envelope protein, and the nucleocapsid protein. So when we developed the methodology, we wanted to make sure that we were really getting something that was complete, that would identify the vaccine immunity as well as immunity to the SARS-CoV-2 virus and be able to differentiate between those. And that's, I won't go through the details, but these are the neutralizing antibodies bind to that receptor binding domain, and that's why they're so important. You can make regular antibodies to other areas of the SARS-CoV-2, but the neutralizing antibodies are the ones that actually bind to the RBD and inhibit the virus from entering the cell. And this is an example of the report. So I'm not sure how well you can see this, not very well, but there's 9 different antibodies that we're looking at. So the first 3 are IgG, IgM, and IgA to the receptor binding domain. The second 3 are IgG, IgM, and IgA to the S1 subunit of the spike protein. And the last 3 are IgG, IgM, and IgA to the nucleocapsid protein, or NP. And this is, and then at the very bottom, that's the neutralizing antibody assay. So this is somebody who's had, actually we can tell by this is somebody who's been exposed to the virus sometime in the past, probably longer ago, and then subsequently gotten a vaccination. We can tell this just by looking at these results. And they've developed a very strong response because they have neutralizing antibodies as well that they produced. And so this should be somebody who is very well immunized to SARS-CoV-2, had both a infection in the past and subsequently a immunization with the vaccine. And what we found is that we can put people kind of into various buckets or categories, if you will. So we can identify people who had no previous vaccine and no previous infection, those that have had previous vaccine or previous infection, or both, who had a suboptimal immune response. Those are the previous infection but no vaccine, who had a robust response, and those would be likely protected. So the 2 on the left are unprotected individuals, and the 3 on the right are individuals that are likely protected. So we can identify a robust immune response with neutralizing antibodies to either vaccinated, infected, or those who are infected and vaccinated, like the previous result that we saw. Not going to spend a lot of time on this. This is just, if anybody has any technical questions, this is just the validation, the robustness testing, and the sensitivity testing that we did for setting up the assay. So it's really interesting. When you have 9 different assays, if you have just a single assay to say the nucleocapsid or the receptor binding domain, you either have to sacrifice sensitivity or specificity. If you have 9, you can set up criterion that allows you to improve the sensitivity and the specificity. And so we set criterion to allow us to achieve 100% sensitivity and 100% specificity with the methodology because we have the 9 different antibodies. This is just showing the neutralizing antibody assay, and I don't want to try to explain that because we'll lose time. This is some research that's been done that has shown that the neutralizing antibody activity is associated with protection against the SARS-CoV-2 virus. That's a study that was published in Nature Medicine. It's a really good publication. After that, there was this excerpt from Stanley Plotkin at the University of Pennsylvania, and he says neutralizing antibodies are it. It's the neutralizing antibodies that correspond very well to protection. That's just that same slide again. And so I'm going to go through 2 really quick studies, and then we'll open up for questions. So this is a first study that we did, 30 participants. This was a client staff study. So this is staff of a client, which I won't disclose who the client was. But the blood plasma was drawn and analyzed. We quantified the 9 antibodies, and then we qualified the neutralizing antibodies. The age group here is 22 to 79. So this is a pretty young group, average age of 44, pretty young group of individuals, and 30 of them. And what we found is some of them had a response like this. Basically, you see everything's gray and nothing's green. Everything is below the detection limit for antibodies. This is somebody who's not been exposed and has not been vaccinated. Okay, there were 2, so out of the 30, there were only 2 that had not been exposed and not been vaccinated. Okay, just to give you an idea of what's going on. Here's another one where this is somebody who you can see there's some greens now, and the greens are actually to the IgG to the receptor binding domain, and the IgG to the S1. So this is somebody who's been vaccinated, and there's no nucleocapsid, so they haven't been exposed previously. There were 2 staff members. These are vaccinated, but if you look at the neutralizing antibodies, they're negative. They're not detected neutralizing antibodies. This is somebody who's developed antibodies, but negative neutralizing antibodies, a vaccine. And these individuals obviously were vaccinated. They thought they were protected. These are pretty young, healthy individuals. And when they found out the results here that they actually aren't protected, then they had to make some decisions, talk to their physician and their provider, and make the best decision for them in terms of what to do to really improve their immune status from this point, and try to figure out why potentially maybe they didn't have such a good immune response. Since there's a neutralizing antibodies negative, despite the fact that we do have some regular antibodies. That's why neutralizing antibodies are critical. Okay. This is an individual. There were 7 staff members that were previously infected with SARS-CoV-2 but not vaccinated. So we know they weren't vaccinated because they told us they weren't vaccinated in this particular case. But you can see the nucleocapsid protein is elevated, as well as the RBD and the S1. Whoops, I'm back one too far there. If you look at the nucleocapsid, the last 2 you see the gray, the IgM and the IgA are gray, and the rest of them are green. That's an indication that this happened a long time ago, because IgM and IgA will go up, and then they begin to go down more quickly than the IgG. So this is somebody who had been infected a fairly long time ago, but then subsequently was vaccinated, and you can see that the IgG response is a little bit lower than the others. So. No, I said this is a non-vaccinated individual. Sorry, I got confused. This is non-vaccinated individual who's just been infected. Oh, I went ahead too far. I didn't get back. Previously infected, not vaccinated, but a very good, robust immune response. Hopefully I didn't confuse you on that. Previously infected, some time ago, not vaccinated, in a robust immune response. This is somebody who's been vaccinated but had no previous infection. Again, the nucleocapsid is all negative. All 3 of them are negative, but no previous infection and a good neutralizing antibody. So this is somebody who's been protected. So there were 7 staff members in this. So 7 staff members that were infected but not vaccinated, 7 staff members that were vaccinated but no previous infection. And then the biggest majority actually were individuals who had been previously vaccinated and were also previously infected with SARS-CoV-2, and there are 12 staff members there. You can see that's very well protected. So if you put all this together, this is what we see. We see likely protected individuals, 26 out of the 30 are likely protected. Likely unprotected, 4 or 13% were likely unprotected in this group of individuals. And you can see if you look at this, the first group is no vaccine and the third group is no vaccine. So if we add together the no vaccines, we've got 9 individuals. So 30% of the individuals were not vaccinated in this group of staff members. 30% were not vaccinated, which is a little higher than the national average at this particular point in time. But it's a small group. On the other hand, 70% were vaccinated. But then if you want to look at the protector status, so 70% were vaccinated, but 86.6% actually were immunized and developed a robust response to the neutralizing antibodies, and so they were protected. So we can see that by looking at both the ability to see whether they're infected or they're had vaccine, we might be able to see that there's a higher percentage of individuals who are actually protected. So we may be getting more close to that overall safety, that group. So one more study and then I'll be done real quickly here. 99 adults scheduled to receive a booster vaccination. So this is an adult living center. 99 individuals, all had been previously vaccinated, all ready to get booster shots or an administration. So that's a good thing. So everybody's going to be getting boosters. Again, the neutralizing antibodies and the antibodies were formed. The age was 63 to 99, so this is an elderly population. The average age was 85 years. There were 83 females and 16 males, so that's just the population that was there. So this is a predominantly female-oriented study. But here's an example of somebody who's unprotected. Now, we know everybody's vaccinated, so this is somebody who was vaccinated, had very little antibody response, and so that and no neutralizing antibodies. So that's an unprotected individual. There were eight individuals who were vaccinated but not protected in this group. Okay, no response, just not protected. They really had no immune response whatsoever. So those are people to go back and look and say, what is going on that they don't have an immune response? Or they potentially had an organ transplant? Maybe they're on an immunosuppressant drug. Maybe they're on another drug. That sort of thing. It's really important. So eight individuals in that group. There were 25 individuals in the next category. They were vaccinated and/or they had a previous infection. So I grouped these together because all of them were vaccinated and/or previous infection, but unprotected. And you can see again, the neutralizing antibodies here are well below the cut point. So these are non-detected neutralizing antibodies. And you can see a lot of antibodies have been produced, but not the neutralizing antibodies have been produced. So made antibodies to everything, but not those neutralizing antibodies that stop the virus from getting into the cell. That's important. It's an important thing to note. And then we had 17 individuals who were vaccinated with no previous infection. And you can see that again. I'm not going to explain that again. We had 49 individuals who were vaccinated and had a previous infection. So this adult living center was pretty good about getting individuals, 49% of the individuals were had both infection and previous, and all of those individuals were protected. Let's see. I'm going to go into the details here. So this is the results in the summary, and I'll be finished up, and we can have some questions if you'd like. But this is where we ended up. Likely protected individuals, there were 66, or 66.7% in the adults. 33% of individuals who had been vaccinated or exposed or who had been vaccinated were still unprotected. And so that's what we're really trying to get to, is identifying the unprotected or the vulnerable patients. And in this population, there were 33% of them that truly did need to have a booster at this particular point in time, or to be looked into to see why it was that they weren't developing a robust immune response. And we've seen this across multiple populations. But I'm gonna leave it at that and open it to questions if you could. But it's a pretty powerful technology.
Yeah, this is really interesting. Thank you so much for this presentation. I think that we could all probably hear this 3 or 4 times and finally, have some clarity on this. But I understand the concept. What can we really infer from this data, the study? What's the clinical application?
Yeah, I think what we really want to do is be able to provide for each individual an idea of what their immune status is related to COVID-19. A number of individuals, and we promote vaccination. I myself have been vaccinated. A number of individuals have been vaccinated, but they haven't developed a robust immune response. We want to identify those individuals first of all. There's also a number of individuals who have had an exposure, and they did have a robust response. And some of the data are now indicating that there may be the individuals, especially out of Israel, data coming out of Israel, individuals that are exposed may be even better protected than individuals who are receiving the vaccine. So we can identify those individuals as well and help to understand that. What we found is, and we've started a larger study, which I didn't even talk about here, but we're looking to follow people over time, because not only do we do tests for the antibodies, but we also have tests coming forward for B memory cells to SARS-CoV-2, and we'll be able to look for the memory B cells to see if we have long-term cellular immunity, and we have T-cell response assays. So we've enrolled now about 450 patients, and we're bringing them in monthly for testing, and we're going to follow them over time. And many of them were unvaccinated, so we picked some that were unvaccinated and not exposed, and we moved them along. But what we're finding is that when they see their results, on the individuals who see the results and they find out that they're completely exposed, they're completely susceptible or vulnerable, many of those individuals are making the decision then to get the vaccination because they realize, I'm not protected.
Right,
And so
yeah.
those are
Okay.
some of the things that we can get from this.
Exactly. Okay, thank you. And just a couple more things. What's the method of testing and what's the cost and how widely is this available?
Yeah, that's a great question. So the methodology is a flow cytometry method. And so we have flow cytometry beads with various antigens, and then we backstain with the various antibodies. The cost is about $149. And I'm the scientist, so somebody's going to really not be happy with me for saying that, but that's what the list price is, and there's negotiations around that and that sort of thing. So I probably shouldn't have even said a number. In fact, I take that back. We'll let others answer that question in the future, because that's not for me to handle. I'm really on the science and medicine side.
Okay. And is it widely available?
Right now, we have the capacity to do several thousand tests per day. And we have developed partners with laboratories in the area. In fact, one of the labs here is Sphere Diagnostics that we partnered with, so we're not actually going out and promoting. We're partnering with other laboratories who are pulling in the testing from their physicians and others, and then sending to us in the central facility in Richmond, Virginia, to do the testing.
Very good. Okay, we have several questions. I'm going to start with Senator Berg.
Thank you again, Madam Chair, and thank you for a very interesting presentation. I have a myriad of questions, most of which I'm not going to be able to ask at this time, I'm sure because of time restraints. I am assuming, and that you know what they say about assuming, never assume. I am assuming that we do not yet have data over time to show how the antibody rate, the antibody levels rise or fall over a period of time. Is that correct?
Yeah, well, some of the data is coming through. So the antibody levels have been measured in the folks who developed the Pfizer vaccine and the folks who developed the Moderna vaccine and the others have been monitoring and started looking at the antibody levels. And what we're finding, and we have been as well, we're finding that you can't really say every individual is different. And so some individuals may not have a response at all. Some individuals may respond quickly. Other individuals their antibodies may go up more slowly, and then their antibodies may come down faster or slower. I can tell you that we've had, several individuals who had exposure to SARS-CoV-2 more than a year ago that still have elevated immunoglobulins, antibodies to the RBD and the S1 and the nucleocapsid, and also still have very robust levels of neutralizing antibodies. But not everybody. So I can't answer that question because there is so much individual variation, and that's why it's important to do the testing in everyone so that we know what their status is.
And do we have a specific antibody level that we know will protect you from active disease?
Yeah, that data is being generated, and actually I brought a a paper here, and sorry, I've only got 7 copies, so I don't think it's going to be enough to go around. But those of you who would like this paper, it was published in Nature Medicine, which is a very, very reputable journal, and it's a study out of Australia where they were looking at neutralizing antibodies and how well neutralizing antibodies protect. And what they find is that you have if you're in the 20th percentile, so they looked at the population distribution. It's hard to explain. Looked at that population distribution of those immunized patients. And what they found was if you're at the 20th percentile in that group, that's associated with protection. If you're even at your 3rd percentile in the group, it's associated with less severe disease if you get a breakthrough infection. I hope that answers the question. So that's what we're shooting for.
And I think my most important question is, do your antibody levels correlate? I mean, obviously, we think they correlate with your ability to get infection. Does it correlate with your ability to be contagious? I mean, do we know that adequate personal antibody levels in you is going to protect the person sitting next to you from you?
Actually, I was listening to Dr. Alvarado speak when I presented this to him, and he gave a very good response. So that's a really hard question to answer because we don't really have the data. We don't know for certain. Somebody who would have a protective status, do we know? We don't know enough about individuals who have a protective status, so it's hard to say. But Dr. Alvarado, would you want to try to address that at all? I think it's possible that they could.
Yeah, I mean, so and that's a good question. I mean, in terms of how much does that help protect? I mean, if you've got IgA, which we know is it's one of the immunoglobulins, that's all mucosal protection. If your IgA levels are high, would stand to reason that would be probably obliterated in that area. So the big purpose of having Dr. McConnell come and present on this really is mostly to educate a lot of our members to think that people say, how come if you're getting a vaccine, how come they're getting infections? How come they're getting on top of that? How come if somebody's had a previous infection, why are they getting another infection? Maybe you're not producing enough neutralizing antibodies. Lots of reasons for that. But I think we need to be educated because we're thinking on vaccine and unvaccinated. That's easy for government to track. It's easy for health departments to track. But really, when we talk about immunity, if you're immunized against something, then you have protection against that, and you'll be able to, and the more people have it, the better off we are as a society. And so I think that's the point of me bringing this forward, is really to say, hey, listen, there's people out there that probably have protection that don't know it, people who think they're protected and are running around like Superman and are not protected. That becomes a concern in lots of aspects. So, we encourage people to get vaccinated if they haven't had it. There are some countries that if you want to go in and pay a visit, they say, we need to see your vaccination card or proof of immunity. We want to see your previous infection and what your level of antibody is, and we'll let you in. So for some governmental bodies around the world are looking at that and considering that adequate or equal to a vaccination. I think that's what we need to start considering and start talking about, because I know there's a lot of tension, I guess, around this topic that we have. There's obviously employers who are requiring some of these things for folks. What if an employer, and I think there was an employer up at one of the universities we were talking about, who a professor said, listen, I've already had the infection, I don't want to take a vaccine, and they allowed him to bring proof and allowed him to keep his job. They required masks and other things at his point of employment, but he didn't have to get one because he had proof of that. How long does this last for? We don't know. I mean, obviously flu, we recommend flu vaccines every year. Why? Because you may have had the flu a year ago or 10 years ago. It may not cover next year's mutations. We recommend a booster every year, and that will likely be the case with this going forward, I suspect, when it comes to COVID, because I don't think it's here to stay. But we're going to have recurring infections. So how long does that immunity? We don't know those answers. It's all brand new for us. But I think for the here and now, for the moment of what we know, there's a lot of folks who have a good amount of antibodies that's protective for them from actually being infected or having an issue that we need to start considering. And I mean, that's been broached and talked about. And I think Dr. McConnell, like I said, he's from out of state. He's a scientist, a guy who works with Mayo. He's got a lot of experience in this, just to present some of the science behind it and some of the things that we've got to start getting people thinking about that topic.
I really appreciate that. But I'll be honest, my take home from this at this point as a practicing physician is that in 63 to 99-year-olds with an average age of 85, in a small sample, very small sample, 33% of those people vaccinated or having had a prior exposure are unprotected. So we have to assume in our elderly population at this point, even if they're vaccinated, 1/3 of them are not adequately safe from getting sick. The other thing I think we have to assume
Correct.
from this data, or that we could
Small study.
extrapolate from this data, is that even if you've had a previous infection, if you get vaccinated, your immune response almost doubles from what your data is showing me. It goes from 23 to 40.
Yeah, yeah.
So, I mean, this is extremely interesting information, but the take home that I'm getting as a well-educated medical professional is, one, you can't just rely on the vaccine, particularly in elderly people. Yeah. And two, even if you've been vaccinated, even if you've been sick, you've had COVID, your immune response will increase with the vaccine. I mean, this is data, guys, that people need to know. I can't tell you how many smart kids I know in this state who say, I don't need to get vaccinated, I'm sure I've had it. We don't know how long your immunity lasts, and we know we can give you better immunity with a vaccine. I have an email.
Senator Burke.
Okay.
Thank you so much. I mean, I love this discussion. We just have a long list of people who want to chime in. So, thank you. Representative Prunty, do you have a question?
I want to thank you for the work, and I want to thank you for bringing this, Senator Alvarado, because I know that I think this information will go a long way to educate young adults who are resisting getting vaccinated because they feel like do as I say, not as I do. And I think they need to know this science. The question I have is, if someone has had the virus, has been fully vaccinated, and then has to go into some sort of treatment for cancer, that sort of thing, would it be wise to get this test prior to starting treatment? Would it be wise to get it after? How would this test be beneficial to someone in that scenario?
Yeah, that's a really good question. And it's not one that I've even thought about before. But yeah, it's a great question. I think it would behoove them to get the test before they go in, and then after as well, to see, because we do know that many of the drugs will cause some immunosuppression to occur. Now, once you've already made the antibodies, this would be a great study, as a matter of fact. I'm sure that somebody is studying it, as a matter of fact. The antibodies that you make are stable for a fairly long period of time. And so does the whatever immunosuppressant drug or cancer drug cause those antibodies to diminish? I wouldn't think so, because they're pretty stable. But we really need to get some data around this, and it's a really good question. But I would want to measure before and after, if we were doing a study, in which I like to do, to see what exactly is going to happen over time, and then maybe multiple time points so we could study it.
Thank you.
And a brief follow-up, Madam Chair.
Yes.
Is it available in Kentucky?
Yes, it is. We have a partner lab here, Spear Diagnostics, that is right here in Kentucky, in Lexington, in multiple locations. And so through them and the physicians that they serve and the institutions that they serve, you can get ordering a physician to order the lab testing, and it will be available. And it can be submitted to insurance.
Thank you, Madam Chair.
With specific codes.
Thank you, Madam Chair.
Thank you. Thank you for those questions. I got that question from someone else too. So anyone can go to their primary care physician and say, I'd really like to check my immunity.
That is correct. So you could go on our website, which is www.aditex.com, and you can put in your zip code, and we can tell you where a location is near you. We're really building this out right now, so there are some locations that we're not going to have a presence, but we're trying to build out all of the United States right now and even abroad, and we've got some really good networking partners that are developing this with us, so we'll be able to make it available.
Okay, thank you. How is this different from
widely.
The antibody test that folks have been getting?
Yeah, that's a good question, because we hear now a lot of people initially said, you can't use antibody testing to assess immune status, and this for several reasons, actually. Some of the original tests were only for the nucleocapsid protein. So if you had an IgG, say, to nucleocapsid protein, which is one that we have, then you would be able to detect natural infections, but you'd never detect somebody's immune response to a vaccination. So that's one problem. The other problem is a lot of the first tests that were developed were, lateral flow analysis, and you form a little bar. There's no quantitation associated with that. You get a positive or a negative, and where's that cut point set? A lot of folks, it's one thing that we do is we spend a lot of time developing this, but if you had the wrong cut point set, all you got is a positive and a negative. So that's a difference. So you can do IgMs and IgAs.
That helps.
But,
yeah, thank you. Senator Meredith?
Thank you, Madam Chair, and appreciate the presentation. I think you're correct. We probably used to spend a whole day on this and still not get our answers to the questions. But just noticing in your sample size, I know it's very limited, but a third of the people had no protection. Doesn't that kind of parallel the flu vaccine as well? Because so many people say, I had the flu vaccine, but I still got the flu.
Yeah.
And we know it's about 60, 70% effective. So is that a fair side-by-side comparison?
Yeah, I think it is. I think we're probably talking about individuals that aren't protected for whatever reason, and the reasons that they're not protected against the flu may be the same reasons that they're not protected against the SARS-CoV-2 virus. And so seeing those similarities is not too surprising. Now remember, that was in an elderly population, and in the younger population we saw more protective status, and so it really is related to age as well.
Well, I think it's important to communicate that, and, not only for the COVID vaccine, but the flu vaccine. A lot of people don't understand that, and they think they have 100% protection. But ironically, I don't know if you saw it today or not, but there was an article in USA Today. The headline was, antibody tests can't confirm if you have COVID protection. And you just spoke to that just a second ago, but just curious if you'd seen that article and if you were in agreement with it. Obviously,
I haven't seen the article. And the answer is, the antibody tests do correlate to neutralizing antibodies pretty well. And we've seen multiple papers that have been out there that say that antibody testings has been associated with protection, but it really is important that you develop those neutralizing antibodies that are going to bind to the receptor binding domain and inhibit the virus from invading the host cells. That's the important part. So you can, as you saw, I showed some examples, and I know it came through very fast, but I showed some examples where an individual had elevated antibodies but did not have elevated neutralizing antibodies. And therefore, those would be the individuals that probably are not protected despite having antibodies. So it's not 100%. There is good correlation between the neutralizing antibodies and the antibodies, but we can't always nail it down with just the antibody test.
Well, I thought one of the most interesting observations in this article was this is the level of antibodies needed to provide protection isn't known. And as, again, you've addressed that earlier, that, well, this is kind of evolving technology, and possibly we do. But I think this is probably one of the biggest obstacles we have is there's information here, and we have a tendency to be selective with it as to, believing what we want to believe. But that's one of the struggles we have is who you're going to believe. But nice presentation. I appreciate it. Thank you, Madam Chair.
Thank you.
Yeah, thank you. We have Representative Bentley next, and then Wilner and Marzian. We're going to have to cut it off after that and move this along. Representative Bentley.
Thank you, Madam Chair Lady. I have about a few ideas I want to ask you, because most people out there don't understand something. One person just texted me and they said, how come IgD and IgE isn't used also?
Yeah, those are other immunoglobulins out there, and the IgD is not as well studied and typically isn't used in laboratory monitoring. The IgE is, and that's one that's going to establish an allergic response. And so we're really not interested in those that are establishing allergic responses to the SARS-CoV-2. What we're really looking for is what the normal immune response is, and that's why we've elected not to include the IgE.
Next question that came in was, we know that the protein spike is a toxin and it attaches to a receptor site. Is that an H2 receptor site?
That is correct. It's angiotensin convertase.
Has anyone studied the blockage of H2 to reduce disease since it's a histamine type site?
Yeah, and this isn't an area that I've studied in a lot of detail, but there are some thoughts that could you use angiotensin, ACE inhibitors potentially? Could they block the site, or could they be useful? And I think some of the early data suggested that maybe so, and I don't think that's really been borne out. So, but it's not an area that I don't want to go out too far and try to make an answer here. But I think there's a possibility that you could, if you're altering the ACE2 receptor, you potentially could be a mechanism other than blocking it with antibodies. But your system is set up to block that receptor binding domain from binding the ACE2 by using the antibodies. But there are potentially other therapies that could be utilized.
2 short questions. First one got sent to me was the Asian resistance and their numbers being so low at the first of the crisis due to their T-cell immunity?
Yeah, I don't know if I could answer that question. Did you want to comment on that?
No way for us to know necessarily. I mean, that's going to be, everybody's different. There's a lot of factors to the immune system. Like I said, we could spend a day. I can give you kind of a quick version of how it works, but you have T cells, natural killer cells, you have B cells. Part of it's memory, so what you get exposed to. But when your body gets introduced to a new virus, your body recognizes it as something foreign. Doesn't know if it's part of me or not part of me. In the meantime, the virus is infecting you. As you're trying to identify it or find some way to put an antibody on it, you start to try to crank that out. B memory cells are going to take several weeks for that to produce enough, of IgG. You're getting IgM initial, but it's very slow. So your antibody response is slow to begin with. That's why you get infections. To know if you have enough T cells or not, again, it could be from lower immune. You don't have enough antibodies floating around to really block these and to knock them out is a possibility. Somebody could have lower natural killer cells, T cells, lots of factors. But I'd be going into an immunology lesson for everybody here. It would take us quite a while to go through an explanation. So it's kind of unknown.
Just one more short one from someone. They asked me with the engineered virus, was that the guanine, adenosine foci?
I don't know. I don't know.
Yeah, you're getting down to base DNA. I mean, that's base DNA. We're not molecular biologists here to be able to go down to that level for people to know on DNA.
Thank you, sir.
Thank you.
Thank you, Doctor. Thank you, Chair Lady.
Of course. Representative Wilner.
Thank you, Madam Chair. This is such an interesting presentation, and I think we can all imagine so many individual applications for this technology and where it would be so useful in treating individual patients. For those of us here, on this committee, our focus, of course, is on population health and improving the health and safety for all Kentuckians. And really what I'm hearing in this from your presentation is that there's a strong argument to be made in defense of the vaccine and why people should get the vaccine. And I wonder if you could maybe help translate for us, for this committee, what do you think the message is, from technology, from your findings of your studies, of what the message is to help people understand the importance of the vaccination to increase their immunity?
Thanks, Representative. I'll take that if you don't mind. I mean, really, the purpose of having Dr. McConnell come and present this is really to provide that information. It's different for different individuals. Like I said, there's people out there, I think, that are vaccinated who think they've got great protection. Most do and may not have it. We're talking about having people get boosters. And people are saying, how come if it's worked so well, why am I getting a booster? This is part of the reason why. People out there who have had natural and don't even know they've been infected and may have a really adequate antibody response and don't even know it. And so I think it has multiple applications. I think it does bolster the idea that people should get vaccinated. I think if people realize they don't have any protection, they're at high risk. We know this Delta variant is very aggressive, and so we're trying to convince people that are out there, if they think they have an antibody level, I've tested, and I've got a qualitative test with a little line that says, I've got antibodies here, you may not have enough, and so you may still be at risk, and you probably should go get a vaccine. So there's people out there that have had it, who may need a vaccine booster, people that have had the vaccine, who probably need a booster at some point as well, people who don't even know that they've had an infection, who might actually be protected. And we've got a lot of people trying to tell others what to do, not to do. I think this is another opportunity that if we can find that someone is actually immunized, that they're protected, something for our employers to consider, for the state to consider moving forward. That's really, it's more or less to provide some information and again, kind of keep it out of the political realm and really from someone who's a scientist from out of our area to come and present information on some of the studies that are being done.
Yeah. Can I add just one little thing is that we're trying to really see what's happening in communities. So as we get more and more data from varying communities, we're pulling the data in from the varying communities. So we could say, what's happening in Lexington, Kentucky. Let's take a look at all of the results from Lexington, Kentucky. What is the immune status of the individuals that we're seeing from Lexington, Kentucky versus from Miami, Florida? We're as the data is coming in, we're putting these into large de-identified groups of communities to try to get an idea of what's happening in individual communities across the country.
Okay.
Thank you very much. It's very helpful.
Yes, thank you. It is very interesting. We have one last question from Representative Marcion.
Thank you, Madam Chair. Fascinating stuff here. So I want a little clarification. So if you get your blood drawn and your antibody level checked, that's just a snapshot in time at that moment. Right. So a week or a month or two later, they may be back down to 0. Is that correct?
Not a week or a month, but in some time. And again, we said it a lot. It's based on the individual. Some individuals can last their antibody response can last for a year or maybe longer. We know some longer than a year. Others a shorter time period. I haven't really seen anybody have a response and go down within 2 or 3 months. It's typically at least 6 months or 8 months or longer before we see individuals with a good response. But again, you may have individuals that don't have much response at all, in which case we need to try to find out why that's happening.
And then do you know if this is covered at the doctor's office by Medicare or insurance? And have you looked at partnering with our 2 major universities who I think U of L is able to provide this test? Have you looked into partnership with our universities?
Yeah, we would love to partner with the universities. I think we have a pretty comprehensive test, both in terms of the way we do the testing for the antibodies and the neutralizing antibodies. But it'd be great to be able to do comparisons to other methods if they wanted to do that. We'd be happy to try to address that.
Thank you so
Excellent.
much.
And the cost. I mean, the cost of insurance.
Oh, yeah.
Sorry, madam.
So the answer is that Medicare does have CPT codes both for the antibodies and for the neutralizing antibodies that can be utilized and billed against.
Thank you. I'm sorry. I didn't mean to cut you off. I thought you were finished. Very interesting discussion. Obviously, everyone is very interested in this. It sounds like there are great opportunities and probably a great opportunity for some good longitudinal studies and to really see how long our immunity lasts. So I know that Senator Berg, you had one more question. Can I just encourage you to catch up with Dr. Alvarado afterwards? Do you mind? We need to move on.
Yeah.
And I know that you have to catch a flight, right?
Yes, I do.
Yes, you do. Thank you so much for coming today. I really appreciate everything. Great presentation. I will ask Senator Alvarado to just stay put because I know the next presentation you're also part of.
It really was my pleasure. I'm going to leave some of these papers if anybody with Dr. Alvarado. So if anybody wants one of those, they're welcome to take
We'd be happy to make some copies for everyone. Thank you.
Appreciate that. Thank you.
Okay, our next presentation is on emergency measures to address COVID-19. We have with us Senator Alvarado is going to stay put. Betsy Johnson is here with the Kentucky Association of Healthcare Facilities, and Nancy Galvani is the president of the Kentucky Hospital Association. I don't know if you're here in person or if you are. I think you're remote. And Dr. Joseph Flynn is with the Norton Medical Group, and Tim Vino is also here. So please make your way to the table, introduce yourselves, and go ahead and begin your presentation.
Thank you. I'm gonna a few more remarks as we talk about this topic as well. I just want to throw a couple of things out before we dive into this. That we've heard about vaccinations, the importance of that. The remaining population we have out there right now is going to be tough to vaccinate. We know that we had an initial surge, people who wanted to get it got it done. It's getting more difficult. I remind people out there using shaming, guilt techniques to try to get people to take the vaccines isn't really going to work. I mean, implying that people don't care about their communities or their families or their loved ones is not good. If anything, I think it's counterproductive. It's time to start getting non-political, medical people, people that people trust, to start discussing vaccinations. I think all the physicians I've spoke to agree that vaccines need to be in doctors' offices for administration. We haven't done a very good job of that in this state. I mean, there's places where you can go, you can get into Walgreens or pharmacies, hospitals, and health departments, but really a lot of our physician offices don't have it because of bureaucracy and forms that have to be filled out. We got to be able to find a way to expedite that to make it easier to get it in the doctor's offices, where if they have a one-on-one conversation, can convince someone to get a vaccine, they can administer it right there. Someone mentioned earlier public service announcements. Again, politicians were no longer effective on this front. For us to be the ones who carry the message, they're going to look at you, whatever the letter is after your name, people are going to make a decision based on that. We've got the spotlight, I think, should have been with our medical providers from the very beginning. And we need something that's also going to start getting our young people aware. I think a lot of times young people think that they're indestructible and that this can't affect them. We got to start engaging athletes who are willing, coaches, again, our physicians, our nurses, even patients who might be struggling or at the point of their worst moment of the illness before they get put on a ventilator, to beg people to do this. Again, those can be graphic images, graphic messages, but we need them. And I think we know that the more immediate problem right now is right in front of us. I mean, we talk about prevention, and that's all great. Right now we have active issues, active COVID, a major surge that we're dealing with, and it's put a tremendous strain on our healthcare system. And again, we can talk about a lot of the long-term prevention, but we've got to start finding out how are we going to address the immediate crisis, which is our unvaccinated patients who are acutely ill and require hospitalization or acute treatment of an active infection to prevent hospitalizations. And those issues are going to be on workforce issues, on monoclonal antibodies, which we've heard about, and also regarding some liability concerns that are here. And that's what we've asked some folks from our healthcare community to come in and present today. I think we may want to start with Nancy Galvagni. I know she's online. I think she also has to catch, there's something in a flight or something she's got to catch pretty soon, so we might want to have Ms. Galvagni present first.
Thank you so much, Senator Alvarado. Can everybody hear me? Oh, thank you. So again, thank you so much, Chairman Alvarado and Chairwoman Mosier, for having KHA here to speak with you today to update you on the latest situation with our Kentucky hospitals. And as was mentioned, like so many other states, Kentucky's facing an unprecedented surge in COVID-19 hospitalizations caused by this Delta variant. The number of COVID hospitalizations is now higher than what we saw at the previous peak last November and December. And I hate to say, with each passing day, the situation is getting worse. In fact, in just about a 4-week period from the end of July to the end of August, we have seen a 340% increase in COVID hospitalizations, growing from just over 500 patients to now more than 2,000. COVID patients are now occupying 1/2 of all ICU beds in the state. Sadly, we fear some people might be becoming numb to superlatives such as unprecedented, but the facts on the ground are very harsh, I can assure you. Our hospitals are filled with real patients, not theoretical ones. Our hospitals are being overwhelmed by an absolute deluge of patients with COVID-19. Hospital beds across the state are full or nearly full. Yesterday, there were only 135 open and staffed ICU beds available statewide. 54% of the hospitals with ICU beds had 0 open ICU beds, and another 35% had fewer than 5. The situation with medical surgical beds isn't much better. Yesterday, there were only 17% of staffed med-surg beds available statewide to treat COVID and non-COVID patients who need hospital care. 17 hospitals had no open med-surg beds. Another 36 had fewer than 10. Our EDs are being overwhelmed. There are patients waiting to get into a bed almost the minute one opens up. 50% of patients in the hospital EDs are waiting for a room to become available. Our hospitals, all of them, are also giving infusions of Regeneron to keep as many positive patients out of the hospital as possible. The pressure for beds being caused by COVID-19 patients is causing hospitals to postpone medically necessary procedures for non-COVID patients. Sometimes called elective procedures, these are not a nose job or a tummy tuck. An elective procedure is a surgery that can be safely postponed, but only for a short period of time. These are things like knee replacements, a hernia repair, or even certain cancer treatments. Postponing elective procedures not only hurts the patients who need them, but it hurts the hospitals financially because the revenue from elective procedures that hospitals provide helps cover the cost of other services that hospitals provide at a loss. And we want everyone to understand that hospitals do not profit from COVID-19 patients. These patients tend to be sicker, they require more PPE, more treatments, and more staff, and they tend to be hospitalized longer. All of that adds to the hospital's costs, not their bottom line. It's also important to recognize that staffed beds are very different from licensed beds. Having a physical bed is not the same as having the staff to treat a patient that might occupy that bed. Staff beds are the only ones that can actually be used to treat a patient. And what we're seeing is the number of staff beds has begun to significantly diverge from the number of physical beds. And that's because our hospitals are facing a devastating shortage of nurses and other qualified workers. And that is limiting the number of patients that our hospitals are able to serve. There are 150,000 open nursing positions nationwide and thousands of open positions in Kentucky. This demand is driving up the cost for staffing, and our hospitals are in competition with other states for the limited number of traveling nurses who might help fill some of the gaps. As you all know, Kentucky has a population that is sicker than most states and more reliant on government health programs to pay the cost of that care. What you might not know is that Kentucky's reimbursement rate from Medicare is one of the lowest in the country. This puts our hospitals at a distinct disadvantage because we are competing with New York, California, Connecticut, the other wealthier states that receive far more in federal and commercial reimbursement to pay for those traveling nurses to help fill the gaps. Those traveling nurses are able to command pay rates between $150 and $200 an hour. There are no discount rates for poor states or financially strapped hospitals. Even hospitals with reserves are burning through them in an effort to serve our patients, your constituents. Hospitals without those kinds of reserves simply cannot compete for trained staff. There are several things that the General Assembly can do to help our hospitals in this time of crisis. First, we would ask that you continue to support your local healthcare heroes who, despite exhaustion, frustration, and at times despair, continue to soldier on in the service to the sick and dying. We also ask the General Assembly to continue to maintain the state of emergency and the relaxed regulations that go with that have made it possible for our hospitals to continue to serve our patients. We hope that you will pass legislation to temporarily, and only during the state of emergency, provide flexibility to allow healthcare workers such as medical assistants, LPNs, and others to work outside their normal scope of practice, only within a hospital and only under the supervision of the appropriate nurse or physician, and under a written plan developed by the chief medical officer of the hospital that the state would approve. This will provide needed immediate relief to enable hospitals to expand their frontline staff, to relieve the strain on capacity and expand bedside care. We also hope you will provide an appropriation to help our hospitals cover a portion of the escalating costs to retain their existing staff and to compete for the limited number of traveling nurses against the wealthier states. Arkansas has already done this. They've provided help to their hospitals from their federal ARPA funds, which are intended to be used to help with the cost of staffing for hospitals and other healthcare facilities. We appeal to you for similar support. The addition of even 1 or 2 nurses in a small facility could quite literally mean the difference between life and death for one of our sick friends, neighbors, or family members. We also want to publicly thank the Department for Medicaid Services and several insurers for waiving prior authorizations during this crucial moment in the pandemic. Those actions are very much appreciated and critical to serving our patients. The future good health of our people depends on us working together, and we at KHA are ready to help do whatever we need to do, and we will do our part. And I'm happy to take any questions. Thank you.
We might want to let Dr. Flynn, if you're there, if you'd like to talk a little bit about, I know we've had a lot of discussions on Regeneron and monoclonal antibodies, so if you could talk about some of the work you're doing at Norton's.
Yes, sir. Thank you. Thank you, Senator Alvarado, for inviting me and for the committee. I appreciate all you're doing. I think this is important, and it's been a fascinating afternoon thus far. So hopefully what we're going to talk about really aligns with what's been talked about more globally. I think stepping back a little bit, if we think about the crunch on hospitals and the healthcare system, we have 2 options. One is you expand the capacity of the hospitals, or we try to find ways to prevent those most in need of hospitalization to keep them well enough to not be admitted. So the first way, and that was brought up earlier, is vaccination. There's no doubt vaccinations work. The data has been shown, and I'm not here to discuss that at length, other than to say we have some other tools in our armamentarium. First of all, since November of last year, there was an emergency use authorization granted for monoclonal antibodies against COVID. Now, Dr. McConnell and Senator Alvarado spoke to some of the biology behind antibodies, but suffice to say these antibodies were designed by identifying neutralizing antibodies in people that have battled COVID, and then synthetically developing these antibodies where you can actually administer it to other patients. The difference between this and, say, a vaccine, I look at the vaccine as putting sprinklers in your house. So if there's a fire, you automatically put out the fire before it's damaging. And I'd say that the monoclonal antibodies are more, you have a fire breaking out, and you can call the fire department, they come over and put the fire out. You hope that it's not at a point where you're causing too much damage to the home, but you do have that ability to put out the fire. And that's what these antibodies do. Originally it was bamlanivimab that was available, and that, because of these mutations, is no longer offered within the EUA. And now we talk about Regeneron, which is a combination monoclonal antibody of casirivimab and imdevimab. And these two antibodies target what Dr. McConnell was speaking about the spike protein, that receptor binding domain, in two separate areas. So it allows to decrease the chances that there'd be a mutation that would prevent them from being active. And we know in preclinical studies and other studies that this does actually work in the Delta variant. Originally, these antibodies were designed around and got the EUA for treatment of people that were symptomatic and fell into some high-risk categories. So if you remember in the early days of COVID, we all studied at great length who was most at risk of being hospitalized, and more importantly, who was most at risk of dying. And it fell into those categories of the people that were older age, so over age 65, those that were overweight, we consider obese, pregnant people, chronic kidney disease, diabetes, those on immunosuppression, and for the reasons we talked about in the last segment, cardiovascular disease, chronic lung disease, sickle cell disease, neurodevelopment disorders, and people that are on chronic medical equipment. So they have ostomies or tracheostomies that need to be managed. So those people as a whole tended to do worse. And what we found with the utilization of the antibody, it had a significant benefit of keeping people out of the hospital and decreasing mortality. Now, we were part of the study early on that looked at more broadly, when do you give these antibodies? And we looked at the hospitalized patient, those in the ICU. We found that people that once they were hospitalized or on oxygen, they tended to do worse and they didn't gain benefit from being on the antibodies. So this was truly one of those opportunities to give patients that are high risk antibodies to prevent bad outcome. Last month in July, there was a second category added to this EUA, and that was in unvaccinated individuals who were at high risk, the categories that I just spoke about, who had a known positive contact. So the idea is to even get a little bit in front of that individual to prevent a bad outcome. So back in November, we spent considerable time trying to prepare for the EUA coming out. As I said, we have a lot of background in this type of drug. I spent my career in drug development, specifically in monoclonal antibodies and molecular therapies. And we developed within our infusion centers a mechanism by which we could rapidly identify people and treat them in our locations. We set it up around ensuring that when patients came to our urgent care, primary care, emergency departments, that they could make an order of the drug, and our infusion area would call the patient, bring them in that day or the next morning, and infuse the antibody. We set up a mechanism so that people outside of our system could also order it through a fax form, and we would call the patient and treat them accordingly. We've treated around 4,000 people thus far, and it's had a profound impact. Several people I know personally that had fallen into the category both within Kentucky and outside have been treated with these antibodies. We do know that the people the first day or so, they may have the reaction because the antibodies are working and they're killing the virus and isolating the virus and decreasing the ability to be taken up in the body. But within a couple of days, patients see marked improvement. So it's another opportunity for us to really have a multi-pronged attack against COVID and to really single out those people that are high risk and give them hope that there's something to do. And I would say, having listened to a lot of the testimony today, I think that while we have a lot to learn, I would say that probably every physician in the room there, and I know there's several, and that are on the the Zoom meeting would agree that we've never seen such rapidity about being able to identify key targets, to identify patients at great risk, and to be able to bring to bear treatments and prevention to actually impact upon not only within Kentucky, but we've been able to impact across the country with a lot of the work that's being done here. So Nancy was talking about the heroes we work with. I work with 17,000 heroes that I bless. I say a prayer every day of thanks to work with such great people. They're taking great risks every day on the behalf of all of our friends, neighbors, and colleagues. And I'm grateful for you all for giving us this time to present some of the work that's being done.
Thank you, Dr. Flynn. I think we'll turn over to Betsy Johnson next.
Thank you. Excuse me. I want to thank both the chairs, Representative Moser and Dr. Alvarado, for inviting us today to give an update about where we are since the pandemic started almost 18 months ago and inform this committee as to our needs. First, I want to say we stand in partnership with Nancy and the KHA, and I adopt all Dr. Flynn's comments as well as Nancy's. My name is Betsy Johnson. I'm the president of the Kentucky Association of Healthcare Facilities and the Kentucky Center for Assisted Living. We represent 272 long-term care providers across the Commonwealth. There is at least one in every one of your districts. We represent the entire continuum of care, skilled nursing facilities, personal care, and assisted living communities. We represent nonprofits and for-profits. Due to the constraints in time, I will start with how things are going today and then focus on our primary need. And again, I adopt a lot of what Nancy said, so don't forget what she said as well. But our primary need, and the reason we're here today, is to ask for support to build back our workforce. So where are we? I guess it's best summed up, we're exhausted. Since May of 2020, there have been approximately 14,624 skilled nursing facility residents who have had COVID-19, and we've had 2,606 residents die from COVID-19. That is according to the data from the American Healthcare Association. The good news is that the vaccine is working, as most of these cases and deaths were before the COVID-19 vaccine was rolled out to long-term care facilities. We do appreciate Governor Beshear for prioritizing long-term care and the vaccine rollout. Today, with the community infections continuing to rise and our hospitals being overwhelmed, one of the safest places to be is long-term care facilities. That is because our elders, the greatest generation, stepped up and received the vaccine in Kentucky. Approximately 85% of our residents have received the vaccine. However, we are seriously lagging behind with our long-term care workforce vaccination rates. As of August 8th, only 51% of our skilled nursing facility workforce is vaccinated. And I echo what Dr. Alvarado says, we cannot shame them. They are people first. We have to understand where they're coming from. And it really does take people, with all due respect to everybody in this room, not politicians, but it takes people at the grassroots level to turn that tide. So that's where we are in a nutshell. And although our needs are great and multidimensional, I'm going to focus my time today on our workforce needs. Change the slide. So the COVID-19 pandemic has only made our workforce issues even worse. They were bad before COVID-19, and now they're in dire straits. For over a year, our long-term care nurses, nurse aides, and staff have been the primary care for our residents, because many of you all know we were on lockdown, right? So our residents could not receive any visitors. So our workforce had to step up and become family as well. And a workforce shortage in long-term care is not the same as a workforce shortage at your fast food restaurant in your community. We cannot shut down the dining room. We are a 24/7 operation. The long-term care workforce is facing mental and physical exhaustion, a lot of fear, and then, of course, a governmental mandate from the federal government that I'll discuss in a second. We value our long-term care workforce, and we want them to be supported and fulfilled in the work that they do. When they are not, and when they leave the long-term care workforce, the individuals that suffer the most are the elders. The woman in this picture cannot walk by herself. She needs assistance. We need a vibrant and well-trained workforce to care for our elders. Many of you all might know that on August 18th, President Biden announced that all skilled nursing facilities will be required to fully vaccinate against COVID-19. The interim final rule is expected at the end of September. We don't know the details of it yet, but we are watching that closely. The CMS federal mandate singles out skilled nursing facilities only and not other healthcare providers participating in the Medicare and Medicaid programs. This places us at a severe disadvantage in competing for workforce. This will cause some of our long-term care workforce to quit, to join other healthcare providers who do not mandate the vaccine, or potentially leave healthcare altogether. And so we did a survey of our corporate members, and these are the responses. So 43% of our corporate members said they anticipate 11 to 20% of their workforce will leave due to the federal mandate. Again, we are already short-staffed. We cannot afford to lose any more of our workforce. And then this is just another summary of that. What do we do if we lose this? And you also see, thought this was interesting, about 4% said that they will leave not only healthcare or to join another profession, but some of them, up to 4%, will stay unemployed. So unless this federal mandate is applied to all healthcare providers, this mandate is going to negatively impact our skilled nursing facility workforce, and most importantly, the care that our elders receive. On behalf of our skilled nursing facility members, I want to thank the members of the General Assembly for including in the budget last session a $29 Medicaid rate add-on. To give you one example of how that $29 Medicaid rate add-on is benefiting our workforce, one member is reporting that the $29 went to pay registered nurses $5 extra an hour, LPNs $3.50 extra an hour, and state registered nurse aides $5 extra an hour, and ancillary hourly staff $1 more per hour. And after that, that $29 Medicaid rate add-on is gone. The $29 that was approved by the General Assembly, and again, thank you, we will not have access to that money after December 31st of 2021. So we need your help. Due to staffing shortages, some of our members are reporting that they're shuttering their beds due to staffing concerns and are unable to accept transfers from our overwhelmed hospital systems. We have laid out some of our workforce investment ideas in our American Rescue Plan Act letter that is referenced here on the slide. I'd be happy to share that with anybody, but it is with both House and Senate leadership, as well as Governor Beshear. However, other states have already provided funding for long-term care workforce initiatives. Nancy mentioned Arkansas. I know Dr. Alvarado's been studying Arkansas, but there are other states, as we list here, that have invested in their long-term care workforce using those rescue plan dollars. And some other ideas include covering travel and relocation costs for new hires and covering staff agency use costs, which have skyrocketed during the pandemic. Again, we're having to turn to agency staff, and those costs have skyrocketed, and those are Medicaid dollars that we're using to pay for that staff. We are looking forward to working with this committee and members of the General Assembly to invest in the long-term care workforce. Thank you.
And I think we've got Tim Vino. Tim, if you're there. Very good.
Thank you, Chair Lady. Chairman, can you hear me?
I can.
Thank you all, and thank you for having me here. My name is Tim Vino, and I'm the president of Leading Age Kentucky. Leading Age Kentucky is based in Louisville, Kentucky, and we are affiliated with Leading Age National, headquartered in Washington, D.C. Leading Age Kentucky also represents the full continuum of service providers for the elderly, infirm, and the disabled. Our members consist of nursing facilities, both hospital-based and freestanding, personal care providers, assisted living communities, and other long-term health care providers for the elderly and disabled. The vast majority of our members are nonprofit, community-supported, and governed by volunteer community leaders. We, like you, remain very concerned about the stability for the future. As you know, collectively, our members have been devastated by COVID, both emotionally, physically, and financially. Obviously, we're here today to identify solutions that the legislature may consider as you and the governor's office work toward a consensus in a special session. My remarks are evenly divided between policies that our members would like to see included in the call and ratified by the General Assembly, and potential uses of ARPA funds to ensure continuity of care as COVID continues to plague our members. We ask you to consider utilizing ARPA funds to stabilize the long-term care safety net in Kentucky and invest in those who provide access to care for our most vulnerable citizens. This funding will stabilize and support Kentucky's long-term care caregiver workforce and COVID modernization costs incurred unexpectedly by our members. There will be numerous and valid requests for support and funding with ARPA money, but we know our profession was disproportionately affected by COVID-19 and remains vulnerable to it and other diseases if investments are not made quickly. Other states are addressing these needs and challenges in different ways, and we have several ideas on how Kentucky could prioritize ARPA funds for long-term care. Workforce is the big, huge issue, I think, for all healthcare providers right now. A stable workforce continues to be a struggle for all long-term care facilities in the Commonwealth. Our members work diligently every day to recruit and keep talent, but the COVID pandemic has made this even more difficult. Long-term care workers are fatigued and faced with many challenges that come with working with some of our most vulnerable citizens. Investing in these programs would improve the long-term care workforce throughout the state and in turn provide the best possible care for Kentucky's most vulnerable. Staffing levels, I don't know any way to sugarcoat it. It is at a crisis point. Members are struggling to provide sufficient staff to cover bed capacity, and we specifically have the following ideas to stabilize this workforce. We're rapid deploy strike teams. We utilize strike teams during the initial phase of the pandemic, and they were largely funded through CARES Act money, and that CARES Act money will be drying up the end of the year, and there's not a whole lot of money left as we are told by the cabinet. So we need rapid deploy strike teams. We also need some kind of funding to help offset the exorbitant costs that we are paying for staffing agencies. Members report anywhere between $80 and $120 an hour that they are having to pay for nurses through staffing agency or traveling nurses. In order to recruit more workers, we are looking for assistance for hiring bonuses, retention bonus, student loan repayment, child care assistance, transportation assistance, and apprenticeship programs. Infrastructure is another huge need. Long-term care facilities, and particularly those that are nonprofit, have not had a lot of extra resources to invest in some of the technologies and improvements that would help manage COVID and other disease outbreaks. We believe the state could create a pool of funding that long-term care facilities could leverage and invest in the following improvements: HVAC modernization. Most nursing homes were not set up with the positive airflow and negative pressure rooms in order to accommodate infectious diseases like COVID. Private room conversions. We have many long-term care facilities, and Medicaid does not incentivize or pay for private room accommodation, and we are looking for some kind of assistance in private room accommodation conversions. It just doesn't work in an infectious disease environment. Automated temperature screening. I think there were some grants that were given to certified nursing facilities through CMS, but there are many providers that do not receive Medicare and Medicaid funding, and therefore was not offered that opportunity for free temperature screening. We thank the General Assembly and the work that they've done, particularly through providing enhanced rates. Those, as Betsy intimated, has been a lifeblood for some members in order to help with these increased staffing, PPE, and other costs that they did not anticipate. Again, there are a lot of other providers that aren't Medicaid that are struggling without this extra bonus.
Mr. Vino?
Yes.
If I could ask you to just wrap it up
I'm
quickly.
ready to do
we only
so.
have a few more minutes and need to get out of the room. We've got
some of the emergency provisions, extend certificate of need, a bed hold relaxation, pharmacists dispensing 30 days, et cetera, we would like to say. But we appreciate your all's thoughtful approach in vetting these issues and hearing our concerns, and happy to answer any questions or elaborate on any of my presentation.
Wonderful. Thank you so much. I know that I've received a couple of questions. This one is for the Kentucky Hospital Association. Many paramedics would like to help with shift work, thus relieving overworked nurses. Is this something the hospitals would be receptive to?
I didn't hear the first part of that, Representative Moser.
Just that paramedics are willing to work in the hospitals and do some relief shift work. Is this something the hospitals would be open to?
Yes, certainly. And some of our hospitals are already employing paramedics. They work primarily in the emergency department, but they're very interested in having them work on the floors, ICU. Absolutely, that would be a great help.
Okay, thank you. Representative Bray.
Thank you, Madam Chair. This question, I guess, is for the Hospital Association. I've spoken with several rural hospitals around my area and to the hospital located in Rockcastle County. Right now, they're down 20% in RNs, 40% in SNRAs, and 25% in respiratory therapists. And what that's done, they've had to close 22 licensed ventilator beds because they don't have the staff to maintain it. And what they've used those beds for in the past was as kind of an induction unit to take COVID patients off other hospitals. So as far as staffing goes, you had mentioned that ICU beds were running at about capacity. Is that because of licensed beds or because of staff issues, or a combination of both?
It's all because of staff.
Okay.
There's only 72% of our licensed ICU beds that are open because of staff. There's only 65% of our licensed med-surg beds that are open because of staff. It's all related to not having enough staff. Hospitals, certainly have wings that are shut down. So what Rockcastle's telling you is absolutely the case. Hospitals can always, they can surge their beds. They could use non-patient care space to create additional bed capacity, but the limiting factor in all of this is staff.
If I may, we've heard of several large hospitals throughout the state that are mandating the vaccination for their employees, and there are thousands of employees who are currently willing to work who are in jeopardy of losing their job. I understand the need to invest in workforce issues right now, but for those facilities, would that be the best use of our money?
So the hospitals that are adding the COVID vaccine to their existing vaccination policy. So hospitals, because we have very sick people in them, they have long had requirements for vaccinations. There's all sorts of other requirements, other types of vaccines that are required. That's really not something new. FDA has approved the COVID vaccine, so those hospitals are adding that to their existing requirements for other vaccinations. You know, a large part, I mean, it's not the only thing, but part of the problem with staffing is we have a lot of staff that are out on quarantine. So, you know, they're taking all that into consideration. If your staff is vaccinated, then your staff is available to work, not off on quarantine. And also they're looking at how can we best protect our patients as well. So those are all things that, you know, have come into play for our hospitals that have decided to add that. Again, they have existing policies for other vaccines. They're just adding COVID, now that it's FDA approved, to those existing policies.
Okay, and then one final really quick. Last year we passed Senate Bill 5, which was liability protection for, among other things, hospitals. The version we passed was watered down quite a bit from what came out of the Senate. I know in a hospital surrounding us, surrounding Rockcastle County right now, they just this past week had to perform a surgery that ordinarily wouldn't have undergone in that facility, but the choice, they couldn't find any place to take the patient, and so the choice was either let him bleed out or perform a high-risk surgery in a facility that doesn't ordinarily do that, which posed, you know, the biggest issue in their mind was what kind of liability are we opening ourselves up to? In your opinion, based on what we passed in Senate Bill 5, are additional liability protection measures needed? Do we need to go further?
We're very thankful, and we want to thank the members of the General Assembly for passing Senate Bill 5. Of course, you know, as you point out, it was a stronger version in the Senate, but we are very thankful for the protection that's out there, and we very much need it. It's important that it be tied to, you know, the emergency, maybe even the federal emergency, because where we are right now is that we are in sort of crisis standards of care. Hospitals are having to ask nurses to care for more patients. That's just a reality. You point out some of our smaller hospitals are unable to transfer out patients that they normally would transfer out because there's just no place that can take them. So our hospitals are having to treat patients that they would not normally treat. And that's just the reality of where we are. But it's very important to protect our healthcare providers that they are not sued because they're operating in a crisis, in an emergency, under, you know, not what is, you know, the normal routine level of care that's out there. So we absolutely have to have those protections.
Thank you, Madam Chair.
Thank you. Representative Prunty.
Thank you, Madam Chair. This question is for Dr. Flynn. In the hospital presentation, I was thinking about, you know, how do you keep them out of the hospital? And you addressed the issue of infusions. What I think I heard was that BAM was effective initially, but now Regeneron is. My question is, how readily available is that across the Commonwealth? I live in rural Kentucky. I live in Western Kentucky, and I know you're in Louisville. And can you clarify again what the window of opportunity is for that to be effective?
Sure. Thank you for the question. The first part, I can't speak for the availability across the state, and there may be others in the room that are better than I. As far as the other aspects, for people that are symptomatic, they need to have been symptomatic within the last 10 days. The sooner an individual gets it, the better chance they have of having a positive response. And that's the same with the preventive indication now, that if I'm vaccinated and I encounter somebody and I'm there with them for more than 15 minutes in a 24-hour period or considered a close contact, the sooner I can get that Regeneron, the better off I'll be. I think there's other, just more broadly, there's other efforts that can be made. You see the addition of virtual hospitals. So the ability to follow people from a day-to-day basis more closely and using remote testing and remote monitoring capabilities to have really work as systems and interconnect is really important. And I think that we're seeing a lot of these go up across the Commonwealth.
Thank you. Dr. Alvarado, do you know how ready or available it is, or how can I find that out?
Thank you. Yeah, so we've been having a lot of discussions. There have been a few of our hospitals that have been doing this work all along. I know in Pikeville and Norton's has been doing quite a bit of administration of Regeneron. You have to be able to give it before they become acutely ill. Once you're in the hospital with hypoxia and you're acutely ill, it doesn't serve the purpose at that point. We've got, I think, a lot of hospitals have Regeneron or they have monoclonal antibody therapy available. It requires a physician's order. And doctors are right now overwhelmed. If you're trying to get into a doctor's office for an acute visit, good luck. You'll be waiting well over a week or more for an acute visit. So to say, hey, listen, doc, I've just got tested positive. Can you send in an order? It's not going to be done for several days. By then, you might be acutely ill and you wind up in the hospital. So we know that Regeneron cuts down admissions to the hospital by 70%. I think Norton's experience is even better than that, up over 90% as far as effectiveness on it. You're going to probably expect some language in the next few days if we get called into a special session of trying to set up regional Regeneron clinics and be able to have our hospitals work in conjunction with the cabinet to start seeing if we can set up areas, at least in every area development district, to consider them to start pooling their resources together to get some kind of a uniform protocol, both on the people that would qualify for it and how it would be administered, and be able to expedite that process for folks that are high risk to get them that therapy and hopefully help give our ERs a bit of relief. So if someone tests positive and they meet that criteria, they can go in and get that done. We'd like to see that done everywhere in the state. And again, there's areas in rural and in urban Kentucky that are doing a good job, but we've got to do it everywhere. And again, pool our resources together. We've been having meetings with our chief medical officers in hopes that they can help us get that accomplished. So part of the problem too is as we use this, there's talk now that there might be some rationing of that from the federal government, from HHS. I hope that's not the case. I know several states like Florida and Texas have already taken upon themselves to do this. I just got wind today that I think that Arizona is committing $60 million towards doing the same thing in their state. So others are already trying to do this, and this should have been done really 3-4 weeks ago. But we've got to start really emphasizing this and getting it out there. People can get their treatment ahead of time.
Thank you. Thank you so much for that work. And Betsy, I just want to tell you that I will advocate to our federal folks about making a consistent policy on vaccinated employees. Thank you, Madam Chair.
Thank you. Senator Meredith.
Thank you, Madam Chair. It's a very brief, succinct question. It's for Betsy. Don't mean to put you on the spot, Betsy, any more than you already are. I understand how difficult this is. If nothing changes over the next year, what percentage of your facilities are at risk for closure?
Yeah, we talk about that a lot, Senator Meredith. I appreciate the question. It's hard to tell. Like I said, they're already shuttering down beds, which causes a clog in the system. And Dr. Alvarado's shaking his head. I mean, I know we've already had some hospitals are having difficulty discharging folks to our skilled nursing facilities when they need beds. So that's just a problem. But we already had a closure during COVID in Oldham County. So that was one closure. And that now that the workforce shortage is happening and with the mandated vaccine from the federal government, I mean, I don't want to guess, but it's definitely a possibility. And it's something that we should all be worried about because we're just aging as a country and these services are definitely needed.
Well, there's been a shortage for some time to begin with, so this just exasperates it. But I hope with whatever plan we come up with, we understand that it's all interconnected with each other, and there's a rippling effect to this. You know, what we haven't talked about today is mandates for vaccinations. That's a conversation for another day and time, but people need to understand, particularly since the Louisville hospitals have already taken that step, that they're going to lose people.
Right.
You know, our issue right now is shortage of personnel.
Exactly.
You have to address that. And while, yes, we require vaccinations for other things in our healthcare facilities, I'm not sure now is the time to do that. And if Louisville loses additional personnel, that means they're going to get them from your facilities, they're going to get them from our rural hospitals because there's just that type of impact on this. One of the things I suspect will happen is we'll see a hyper increase in wages for nursing personnel in the metro areas. In rural areas can't afford to do that, so it's going to draw those people away from there, and I think we'll be at risk for closure of your facilities, but also closure of rural hospitals. So we need to understand we're all in this together,
Right.
And there's got to be kind of a symbiotic relationship here, and it can't just be everybody for themselves. So we just need to be careful where we go with these things. But I certainly understand your situation and wish you the best. And
Thank you, Senator.
Thanks.
Madam Chair.
If I can comment, Madam Chair, Senator, there's, some of the wages people are talking about are $150 an hour for nurses, and good for them. I mean, these are hardworking nurses. They do God's work. They do tremendous work. But what's happening now is as soon as we lose them, they've gotten recruited away because other states have already done this a year ago. They've been devoting CARES money, which we didn't do. We devoted $70 million towards contact tracing. We devoted $1 million towards lotteries, but not towards retention and recruitment of nursing staff, which is really critical. What we've got is $150 an hour, husband and wife, both nurses, have 2 kids. Hey, listen, we'll move you to another state. We'll pay for your housing. We'll pay you that kind of wages, and you sign a 2-year contract, and they're gone. So we have a surge right now. It's going to probably peak here in a bit and probably drop back. We'll probably have another surge in the future. And that's going to happen in 4 months or 6 months. And those staff aren't coming back. They're gone. And they may be gone permanently at this point. We got to use these monies to really to retain a lot of the nursing staff we have because they're being poached by other states. And it's a crisis situation. It's not just nurses. It's nurses' aides. It's respiratory therapists. It's paramedics and EMS folks. It's all the folks that are critical as far as COVID. We've got to do something. Other states, again, I think South Dakota is offering $40,000 as a signing bonus for a 2-year contract for a nurse, courtesy of the state government there. Georgia has devoted money. Missouri's devoted money. Texas has got their own agency to help work with agency nurses to pay a part of their portion of salary to keep them there. We're behind the 8 ball already, a year behind, because we didn't act on this a year ago when the administration was made aware of this issue. Now we're facing a lot of the critical issues. And if we keep losing staff, I mean, I see 300 patients every month. I take care of them. I went to do rounds last night, pretty late, but I went to one of my nursing homes to see folks. 40% of those folks are vaccinated of the staff. So if a lot of them wind up leaving, again, you lose one shift, you shut the nursing home down. Imagine if you have 100 people, where do they go? And they're all elderly. Our hospitals can't take them. Folks at home can't take them because they'd be there anyway. That's going to be a crisis situation. And so a federal mandate coming down is going to have major reverberations for us as a state if we're not able to keep staff there. It's going to be a tremendous struggle. I fear what might happen here in the next little bit.
What, $150 an hour? I can tell that you regret going to medical school now.
Honestly, and good for them. I don't harp anybody for making as much as they can, and they're skilled employees. And our nurses work very hard in this state. And this COVID is just the camel that broke the camel's back. Liability, we're one of the worst states as far as lawsuits and medical malpractice in the country. That's part of the problem. Part of it also for our nurses is the bureaucracy. They're doing more paperwork than they are seeing patients. It's a burnout situation just from electronic medical records to government to insurance to liability. And here comes COVID on top of it. And someone's saying, hey, I'll double your wages if you move away. They'll say, you know what? It might be greener over there, and they're willing to move away. Once you lose them, they don't come back. We've got to find a way to recruit and retain the staff that we already have.
And that's one of the reasons that I would hope that maybe we could put this vaccination mandate on the back burner for the time being, because we forget that people in our healthcare facilities have been dealing with COVID for almost 2 years now without this mandate. We've asked them to put their lives on the line before there's even a COVID vaccine available, and now we're telling them, you've done this for a year and a half. Now we're going to let you go. That's just not the right way to treat people. It's not respectful. And I think there's some real arguments to be made about the cost-benefit analysis of doing it this way. Got a text from a patient last night, a family member, that he's got stage 4 cancer and he can't get his surgery scheduled because of the current shortage. Yeah. Well, reducing the number of personnel by forcing a mandate is not going to help that situation at all. So again, let's focus on the issue at hand. It's the shortage of personnel. Whatever we do, and it makes it better, it makes it worse. There's no middle ground for this, and that's the context we need to use for making all these decisions. But thank you again, Madam Chair. Thank you.
Thank you. Senator Burke.
Thank you, Madam Chairwoman. And honestly, I could ask questions from here until tomorrow morning. First of all, I would like to just make a statement. I have been a healthcare provider for over 30 years now. I am required and have been required to have an annual TB test and an annual flu vaccine as part of my employment. It is not a choice. I have no option but to do this and have never had an option but to be tested and vaccinated. So why, all of a sudden, are we making exceptions for healthcare personnel when we have one of the safest, documented, safest, and most effective vaccines that have ever been developed. And you had to have a TB test to take that job. Your healthcare workers did not walk into that facility without getting a TB test. If they are willing to get a TB test for a basis of their employment, what is the difference between that and mandating a COVID vaccine? I do not understand the difference other than the political environment in which we are living. If we take away those politics, the rules are the rules that have always been the rules. And my employer...
Senator Berg, do you have a question?
Okay, yes, I do have a question. My understanding is that right now, statewide, our current staffing levels in the ICU are 1 nurse to 4 patients, which is double our current rate, which is 1 to 2. We like to run 1 nurse to 2 ICU patients. We're at 1 nurse to 4 ICU patients. We are at 1 nurse for 7 to 9 med-surg patients in the state right now, which basically means if you're in the hospital and you just had surgery, you're one of 9 patients that 1 nurse is taking care of. Essentially, you don't have a nurse. I have a big concern that we're going to put lower level educated healthcare employees like paramedics, put nurses in charge of overseeing them who are so busy taking care of patients that they have no ability to oversee those patients. I don't want us to destroy the quality of our healthcare basically to accommodate what I perceive as an overwhelming misconception about what is safe and what isn't safe.
Okay, thank you. Thank you. Senator Carroll.
Thank you, Madam Chair. Betsy, can you talk a little bit about the precautions that are still being taken within the industry, especially dealing with staff?
Right. So under the current rules, if a facility's in a red county, which unfortunately most of our counties are currently red, those staff are getting, the unvaccinated staff are getting tested twice a week. So that's happening. One thing we had to learn at the beginning of the pandemic, which we're not used to because we're not a hospital-like setting, but PPE is being worn constantly. There's isolation wings. So all those protections are still in place, and we're still working every day to encourage the vaccine among our members. To one of Senator Meredith's points about workforce and mandates, we supported all our members that mandated it. I mean, they stepped up as an employer. They decided it was the right decision for them to make. I have an independent owner in Louisa, Kentucky, who was one of the first facilities to get over 75% of his staff vaccinated. But even with this federal mandate, he's concerned that he'll lose his entire 3rd shift because they are the unvaccinated workers. And as I said in my presentation, we are a 24/7 operation. So again, I hope we can all work together because our healthcare workers are human beings. We have to fight misinformation. I so admire Representative Moser and Dr. Alvarado and many of you all who have been out there trying to explain the importance of the vaccine. But we are taking all those precautions. I mean, we were doing that during the flu season too. COVID is different, but we are working 24/7 to keep our residents safe, and we're doing a good job. We really are. I mean, if you see the graph, it went way down after the vaccines, and we're doing everything we can to protect them.
Based on what I heard today, why are we not testing those who have been vaccinated?
It's not recommended by the CDC. Oh, we are testing people that haven't been vaccinated.
Those that have been
not,
vaccinated,
sorry. So if you're vaccinated, you do not have to get the twice-week nasal
Why?
swab.
I mean, there's still, a 30% chance? That
Yeah, and that's true. And we're talking about that. And there's some facilities that are going ahead and testing that. But I would tell you that the CDC guidance does not require it.
Okay, thank you. Thank you, Madam Chair.
Mm-hmm. Thank you. Senator Wise.
Thank you, Madam Chair. Yesterday in the Education Committee, we talked at length about quarantining for young people K through 12. And a large portion of those quarantine were not positive, but because of contact tracing. I don't know if this is for Dr. Flynn or for Nancy. Where are we right now in that age group in ICU or hospitalization? Do we have any of that data? We really couldn't find the data yesterday of how many of those statewide K through 12 in quarantine are truly positive or just because of contact tracing. So I didn't know if there's any data or information showing specifically for K through 12 as it relates to ICU or just hospitalizations.
I do not have that, Senator Wise. I don't know, Dr. Flynn.
I don't have it broken down by age, but I can say that we've seen a horrific spike in children being admitted to our ICU in the Norton Children's Hospital. If you look at the initial spike of COVID, it was rare to see a child other than MISC as an indication for admission. Now, as of yesterday, we had 20 inpatients that were children. So I think that speaks to the very nature of what we're seeing, this kind of dichotomous look at what's happened from COVID standpoint.
One quick follow-up, Dr. Flynn, on that. I hear from a lot of hospital CEOs in my district that it's a RSV issue, not so much a COVID-19 related issue. Is that the same of what you saw yesterday with those numbers?
No, so you're exactly right. RSV had a summer peak, which we typically don't see. Normally we see it in the winter months, and we have seen a spike. So we have seen an increase in RSV, but also in COVID.
Thank you.
Thank you. And our last question is Representative Rayburn.
Thank you, Madam Chair. This question is for the Kentucky Hospital Association. Earlier, you had noted that most of the staffing issues are due to staff that are currently being quarantined. Can you tell me what is the current protocol for that hospitals are using to quarantine staff? And also, are we quarantining staff members that have already received the vaccine as well?
So I want to clarify that is part of the problem. That is not the only problem. We have had people resign. We have less staff now at this dealing with this Delta variant than we had at the prior peak of the pandemic. We've lost nurses because of resignations, because people have decided they want to do something else. But part of the problem is staff who have had an exposure, on quarantine. And, I can't tell you the exact, we're following whatever the CDC requirements are with regard to quarantine. Dr. Flynn might know more.
We are following the CDC guidelines, and the guidelines state that individuals that are vaccinated, there's a different level of thresholds for bringing them back. Typically, you'll get tested at 3 to 5 days, and with a negative test, they can come back to work. Those that are unvaccinated, because of the trajectory of what happens with the virus and their potential for actually having symptoms day 10 to 14 or later, it's slightly different with them. And if I could just add one thing, because I've kind of been watching the discussion, if you don't mind. I think we have to understand, I think Senator Alvarado said it nicely when he talked about there's a whole slew of issues, and it's easy we focus on one aspect of it, and whether it's quarantine or people going to other states. But there's been a lot of people that have retired that just said, I can't do this any longer. And the longer this COVID pandemic goes on and impacts people, you're going to see people just leaving healthcare, because it is a very, for those of us who have been in healthcare a long time. I served in the military. I was at a number of different things and seen a similar type of episode with just constant onslaught of sick people and people dying. And if you haven't experienced that, it does have injury to all of us. And I think we need to understand that this is more than just one simple solution. This is taking a multi-tiered approach and trying to make sure that we keep people at the center of what we're trying to do, keep them healthy so they're able to work, but also understand that there's a lot of things that are pressures on them each and every day. And I think I just hope we all continue to laud all those people that are sacrificing and going there every day to put on the PPE to take care of these people.
Thank you, Dr. Flynn. Thank you to all of our presenters today. This has been a really crucial conversation that we have to have. And rest assured, we are looking very carefully at all of the regulations that we need to keep in place to really support our healthcare workers, our hospitals, our long-term care facilities, all of these folks who have been called heroes, and they are, all throughout this entire pandemic. And I believe, I I could say a lot of things. I think everything really has been said. I just really appreciate all of your work. And Dr. Alvarado, do you have some final parting words for us?
Just briefly, for those who are going to be wondering what we're going to see based on the testimony today, I think you can expect us to be looking at the funding to help with retention of staff and recruitment of staff, both within long-term care. I think that has to include nurses, aides, respiratory therapists, even EMS personnel, even to consider using paramedics who work in our ERs right now and provide care there, to maybe expand what they're able to do at least in other aspects to help us with Regeneron clinics or even on the floor if we have to in our hospitals. Another thing that we've heard from a lot of our hospitals is rapid COVID-19 test kits. They're running out. We're talking, I think in education, they talked about yesterday to see if you could test, kids more frequently. We're woefully short. We're having to use PCR tests. We've got to be able to get more of those rapid tests for our hospitals, for our health departments to do those more rapidly so they can really triage patients more quickly. And then I think we're also going to be looking at consideration of trying to find ways to help administer Regeneron in a regional capacity. We're also looking at a lot of the things that we did in Senate Bill 150 in 2020, House Bill 1 this past year, House Joint Resolution 77 for a lot of the executive orders, regulations for all of our boards to try to help extend that at least for a period of time and maybe even until we get back into general session to make sure that a lot of them can still have the liberties to help recruit people that might be retired, people that are willing to come in and help in terms of providing care. We're also looking at liability. That was still a big issue. And to Representative Bray's point, I mean, a lot of our hospitals are concerned about having to do more. We need to be able to extend that protection for folks as well. So just watch for that in the days to come. Thank you, Madam Chair.
Thank you. And Senator Carroll has something really important to say.
Personal physician administration of the vaccine. You said there's a lot of red tape involved in that. Why is that different from a flu vaccine?
Yeah, it's exactly right. So Johnson & Johnson is the one that we can be stored in a doctor's office easily with no issue. The other ones require much colder temperatures. But even to get those, they have to, apparently there's a lot of different forms they have to fill out to get, and most physicians I know are pretty averse to more paperwork. The worst words a doctor wants to hear is, doctor, all you have to do is, and fill in the blank. You hear that, you're like, oh, another thing I got to do. So a lot of them aren't doing it. We're going to be asking probably for an easier way to be able to get those into doctor's offices, because if that one-on-one conversation happens and somebody says, okay, I'll take it, you can give it right then and there instead of sending them someplace else where they might lose their courage or change their mind.
Yeah, the comments that I get, I think that could have a huge impact. I mean, getting it in the office or going to a room they've got set up at the mall, I mean, where is the most credibility? Yeah. Obviously in the doctor's office. Yeah. Absolutely. Thank you, Madam Chair, for the latitude.
You're welcome. Excellent point, actually. So thank you so much. Seeing no further business, we will adjourn.
Thank you. Thank you, Dr.